Broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This
Today's meeting of the Health Committee. Members of the public may like to follow along at London Assembly on social media and use the hashtag #AssemblyHealth. Can I remind participants to silence your devices? The main items on our agenda are breast cancer screening in London and public health messaging on Transport for London. However, we have a few short items first. Can I ask our clerk, Diane Richards, to confirm any apologies?
Thank you, Chairman. No apologies for absence have been received. However, in accordance with Standing Order 2.4D, with permission from the Chairman, Assemblymember Wilson will be joining the meeting remotely today.
Thanks, Diane. On declarations of interest, can we now list can we note the list of offices held by Assembly members? And can I also ask members if they have any disclosable pecuniary interest in any specific items listed on today's agenda? No. And noted of the list of offices? Thank you. Minutes. Can we confirm the minutes of the meeting held on the 26th of November 2025? Thank you. And summary list of actions. Can we note the completed and outstanding actions arising from previous meetings and additional correspondence received? Thank you. Action taken under delegated authority. Can I ask the committee to note the action taken by me as chair under delegated authority in consultation with party group lead members to agree the committee's men's mental health in London report? Thank you. Right, on to our main item of business today. I'd like to extend a warm welcome to the first panel of guests. We have Helen Dickens, Chief Support Officer at Breast Cancer Now, Lee Dibben, Education and Policy Manager at Outpatients, and Leanne Graham, Advocacy Lead at Black Women Rising. And if you get me a second, I'll get to the first question for you all today. I think I can find it. Okay. Helen, I'll start with you and work this way. Why does London have the lowest uptake of breast cancer screenings compared to other regions in England?
Okay, thank you, and thank you for bringing this topic to the debate today. Really important that we look at all of the reasons why uptake of breast screening can be low across the country, and we know that London has one of those lowest uptakes, as you've said. I think in our last data, that uptake was around 62.9%, about 7% below the average across England. And that's something that obviously we would like to see increase up to the target of 70%, and also what we see as the achievable target of 80% of women uptaking their screening invitation, because we know that screening is obviously a really important tool for getting people an early diagnosis of breast cancer, and that early diagnosis we know saves lives. So really important that we take action to tackle that. There are a number of different reasons why uptake can be challenging. Some of that is sort of general across the breast screening programme nationally, and some of those factors are compounded in London. And so we've been undertaking some research specifically in London to understand what some of those barriers and opportunities are to improve uptake. And so I'll talk through some of those. I'm sure others on the panel will be able to delve deeper into these. But one of the challenges we have still is around awareness and understanding of breast screening. We conducted some national polling that found that around 19% of the women that we polled didn't attend their screening because they didn't feel comfortable with the idea of someone screening part of their body. And 11% were worried about pain or harm associated with screening. And we know that for some groups of women, these fears and issues around trust and accessibility are going to be even higher than others. And obviously with the diversity of our population in London, we know that there will be a number of women who will experience even higher levels of fear, levels of accessibility issues and understanding of when and how to access their screening. Some of that is around cultural and understanding and awareness, but some of it is also physical barriers. So, I mean, again, in our national polling, we found that 16% of women who didn't attend screening, it was because they couldn't get to a screening centre. And while in London, obviously, we have amazing public transport and we feel that we've got great accessibility, we also know that we don't have screening centres in every borough. And we know that for some women, that barrier of transport and access will still be a really big reason why they're not attending screening. For those with physical accessibility needs, again, understanding whether or not that access will be available to them is another reason why they might be put off attending their screening. We also know that there are issues around data. And particularly in London, we have a high level of transience in the population. So for people who perhaps are not accessing healthcare through their GP, they may not be receiving their invitations. We also know that the data held by those GP practices that are shared with the breast screening programme may well not be up to date. So we've heard from breast screening providers that when they try to follow up with women to understand why they didn't attend their screening, often the data that they have, the phone numbers, the contact details, they're not relevant anymore. They're not being used. Perhaps those women have moved on and we're not able to contact them. So all of those reasons together really do compound the issue of uptake of screening in London. And I suppose the final point I just wanted to make on that is that we also know that there is incredible work going on across London looking at how we can increase uptake. And there are some pockets of really great practice out there. And you know, we really urge everybody to be thinking about how they take those, learn from that best practice and roll it out. Because one of the issues that we've had from the stakeholders that we've spoken to is that funding might be short-term, projects get off the ground. We learn some really great learnings about what works to reduce some of those barriers for people to attend screening, but we're not able then to share those across other boroughs and other parts of the region. So that's an area we really think that we could be building on, thinking about across the system, how do we really make sure that breast screening and uptake of breast screening is something that everybody can take part in so that we're giving women that best chance of getting to their screening, having a great experience when they're there, and hopefully being able to diagnose breast cancer earlier.
Thanks, Helen. Lee, did you want to give your thoughts on that?
Yeah, absolutely. So obviously we deal with lesbian, gay, bisexual, transgender, intersex and queer communities, which are a higher percentage of the London population. So we think more about those specific health inequalities that sit within the breast screening programme for our communities in particular. When we're thinking about our community, we capture quite a broad range of experiences and needs within that initialism. So we need to kind of break it down a little bit. So what we see in women who have sex with women, so particularly lesbian, gay, bisexual women, is that they do show lower attendance at breast screening programmes. That's often due to a misunderstanding that this is something that they should engage with. We've done a lot of work, particularly in 2021, with the North East London Cancer Alliance to understand what were the actual perceptions of breast screening and barriers for our community. And what we heard a lot was that people didn't feel like it was for them. It's a very hyper-feminised space within cancer. It's very pink, and that really doesn't work sometimes for a lot of lesbian, gay and bisexual women. It also doesn't work for a lot of women who are straight as well. So thinking about that diversity of messaging is really important across the board. We also know that people have had previous negative experiences within healthcare settings across our community, which can really contribute to their intention to actually present to healthcare. We see what we call quite high levels of medical mistrust and avoidance within the community. So someone in that focus group shared that from the experiences that they'd had and the experiences of their friends that routinely skip those screening appointments, it was because of a really deep-seated fear of how they were going to be treated within those healthcare spaces. So there's a lot of a trust deficit that needs to be bridged through things like inclusive campaigns and messaging. We also have some specific difficulties for transgender populations. So the way that breast screening invitations work is that it is sent to everyone with a female or an I indeterminate marker on their NHS record. What that means is that if you have a male marker, you're not routinely invited to that programme. There's also no good way for you to access that programme. You often have to call up the breast screening team. You might be put down a symptomatic pathway. So within that male NHS record marker, we might have some transgender men who had developed breast tissue through puberty and haven't had top surgery, which is that masculinizing double mastectomy to remove it. So they still need breast screening. We might also have some transgender women who have taken estrogen as part of their transition and they've developed breast tissue. When they do that, their risk increases to about just below that of cisgender women who haven't taken that feminising hormones. So they should be accessing the programme in the same way. That's the current recommendation. But if they have that male record, either because they haven't re-registered it or because they have re-registered it if they're a trans man, it means that they're not routinely invited. So we're seeing a system that isn't quite well designed to manage the nuances of the communities that we now see within London. Within cervical screening, they've introduced an opt-in update to allow people with a male record to opt into that screening programme if they have a cervix. So the same programme for breast screening would be fantastic. It would allow that nuance, those people to actually present when it's relevant to who they are. So I'd say they're my kind of high-level barriers.
Thanks. And Leanne?
Hi, thank you for having me here today. So,
Just the right side.
thank you. Thanks for having me here today. So, at Black Women Rising, our members are women of colour and Black women in the community who have experience of breast cancer. They range from all different ages. And through our 100 Women survey, which we conducted in 2021, we found that a lot of our members and a lot of the women who are struggling to access service for various reasons, many which have already been mentioned here today, so cultural barriers, a fear and a mistrust of the health service due to previous experiences and word of mouth within their own communities. Especially a lot of our members are quite young, so they don't actually reach screening age. I was diagnosed with breast cancer at 35, so if I didn't know how to find my own lump, I wouldn't have ever accessed the services anyway. And as we work through our membership, we find that many of our members are actually underneath the screening age, which makes it really, really difficult to, one, understand how we can get on the pathway when it comes to screening, but two, being listened to. There's a lot of medical mistrust within the Black community, which has been ongoing for many, many, many years. We find that women of African origin don't trust the service as much and won't go for their screenings. They don't think they need to. There are a lot of religious barriers that come into play as well. And so for us, it's about educating as many people to recognise, one, the changes within their body, and two, how they can overcome what culture has told them for many, many years to make sure that they are listening to what's going on with themselves. Having access to culturally appropriate materials which are going to encourage everybody to go and get their screening is important. Again, when I got my diagnosis, I didn't really see any women of colour on the materials that I was receiving. So that didn't let me know that I was welcome in their spaces. We often find that we're not listened to. We find that Black women are told that their pain and their symptoms are not what they think they are. And we're told to not trust our own instincts. So that then creates further barriers, especially when we repeat that to our friends, our colleagues who are also Black or women of colour. So breaking down the mistrust, understanding that we are able to access services is going to be really, really important. We know within the community that we often have communications where we're told that we don't need to go for screening, that Black people don't get breast cancer. We know that's not true because more and more women, younger as well, are presenting with those. So those are some of the key challenges that we have within the Black Women Rising community.
Thank you all for the opening comments. And if you look at the variation across London, obviously we said it's one of the worst in regions in England, but it's almost like a perfect donut of it starts okay and then it reduces as you go into London. And that kind of probably reflects a lot of the barriers you've already discussed with those population demographics. But are there any other barriers that you think aligns with or explains that variance aside from the population demographics we've already kind of touched on?
Thank you. I think one of the challenges is looking across the region and understanding those inequalities. When we speak to providers of the breast screening service and stakeholders, I think what they tell us is that there are some quite systemic issues with the programme itself. I mentioned around kind of data, how the system works to kind of collect that data, understand who's being invited, making sure that those invitations go out, that we are flexible in how we allow people to attend their screening. And I think that might be part of it as well. We've talked about some of the barriers already around perhaps culture, around people's individual barriers around kind of coming into screening. But thinking about it from a socioeconomic perspective as well, We also know that often you might receive your invitation, it's a particular time, there's very little flexibility. If you are someone who is reliant on getting to work or you have caring responsibilities, often it does not fit in to that. And so I think that might be one of the other drivers of that variation that we see, as well as understanding where have we got really good access to a local space or area where you feel comfortable and are able to attend. And that's something that we would really recommend looking at, is within communities and within areas of London, how accessible are the breast screening services? Are there any ways that we could be putting more mobile units in place? Different ways that we can ensure that this fits around people's busy lives. That might be one of the other areas that's driving that, that variation.
Thanks. And Helen, you began to touch on it then, but is there any action that the three of you would like to see happen? What would be your big main asks of change to increase screening?
For us, it would be updating that invitation process to have that opt-in update. It is on the radar of the national screening team as part of their digital transformation work. However, it has been quite consistently deprioritised. So it'd be nice to see that kind of introduced, particularly with the upcoming cancer plan, and that we've seen a success of it within another screening programme already. I also think there's lots of learnings that can be borrowed from things like lung screening, which we've seen have a really transformative effect on actually flipping the picture on who is diagnosed with lung cancer, right? If you're living in the most deprived areas, you're now more likely to receive an earlier diagnosis. So thinking about risk-stratified approaches that take into account all of these different things so that you can target it better. Those mobile units, are they accessible as well? We know that disabled people really struggle physically to access things sometimes, and often the information provided isn't as useful. So echoing all of those things as well as the specific too.
I think being able to tailor it to the community that we're trying to get into. So if we know that there's low uptake in areas where it's mostly women of colour, or it has a high percentage of women of colour, how are we really reaching out to those people to make sure they understand what happens as well within those screenings? If you've never been for a breast screening before, the thought of having a mammogram can be really, really terrifying. Also, not understanding the processes that happens around it. So if you're going to a one-stop shop, what's happening at a one-stop shop? Are we going into the spaces where black women and black people gather regularly to help them understand why it's important that they go for their screenings? Are we going into churches? Are we going into community groups? How are we making sure that we're really reaching the people who are not being who are not being reached and who are not understanding why it's important to go for their breast screenings? So I think my ask is to make sure we understand the communities that we're going into, how to speak to them in a way that it's not going to be frightening, it's not going to be overwhelming, and really understand what the process looks like for them to get acceptable kind of care within their needs.
Thanks. Helen, did you want to add anything?
Thank you. And yeah, I would add to that as well, actually, around, you know, that awareness is incredibly important. We really welcomed a national awareness campaign around the screening programme that was rolled out last year. We're waiting for the results of that, but I think once we have that, what we'd really love to see across the London region is taking those learnings on board and thinking about how we can continue to raise awareness of the importance and accessibility of the screening programme, but talking very much about those barriers that for some women are kind of higher than others. You know, what we hear is that, you know, when we send out invitations to the screening programme, you know, it's not very clear, as you were saying, and actually there are opportunities for us to add more in there. Some of the feedback that we've had specifically around, you know, those invitations in London would be people want to know about things like radiation risk. That's something that might be putting them off. They're concerned that a man might carry out this procedure. And so being able to address some of those concerns as we go through the communication of the programme and those invitations, I think would be incredibly useful. And similarly around language barriers, we know that invitations can often go out in different languages, but the other information that we have about the programme isn't available and accessible. So again, it's just compounding some of those barriers that we've talked about. So I think awareness, making sure our communications are as open and as accessible as possible would be really, really key. I think for breast cancer now as well, we do a lot of work with the providers of the programme, with the stakeholders, with the healthcare professionals who are talking to people about the screening programme. and actually being able to understand where those best practice pockets are, what can we learn from, and how can we pull those into really good practice across the whole region. It can feel quite piecemeal and a bit fragmented, and actually there is an opportunity, we think, across London to look at all the different stakeholders who could play a role in encouraging people into breast screening. So that's from the GP and local health services. Making every contact count is still a really important concept so that people are able to have a conversation about screening. But we also know that the screening programme commissioning will move into integrated care boards over the next few years. That's a real opportunity to look across the system in London and think about what are all the different touch points that we have to be talking about the breast screening programme, making sure women feel comfortable and removing those barriers, as we've talked about, to make it flexible, accessible and easier for people to attend.
Thanks. Going to pass over to Assemblymember Harane.
Thank you, Chair. Just want to follow up on a few points that I think, Helen, you touched on mostly. So I'll address these questions to you. Just on the lower uptake of screening, first of all, 7% lower in London compared to the rest of the country. So do you have a sense of whether that's leading to worse outcomes for Londoners as a result?
Yeah, that's a really great question. I mean, we know that obviously the breast screening programme supports earlier diagnosis of breast cancer. If you're diagnosed at stage 1, your 5-year survival outcome rate is 98%. You know, that's where we want people to be. Obviously, if you're diagnosed at a later stage, we know that treatment can be much more brutal. We know that outcomes obviously can vary. So for us, it's absolutely about getting people into that earliest possible diagnosis. So when we look at the outcomes for breast cancer in London, you know, partly driving any variation will be the variation in screening uptake. So I don't have the figures to hand today, but we know that if we can drive more people into screening, we will save more lives, and that's really important, obviously, when we're looking at this. The other thing that I would flag there is that not only across London are we seeing that kind of below average uptake, there is big variation, as we've talked about, across London itself. So in some areas, it's much lower than the 62% that I've already cited.
Okay. Yeah, no, that's helpful to hear. And if you have some of that data, I think we'd appreciate it as a committee outside of this meeting. And just one of the solutions that you pointed towards was mobile screening. Now, parts of London, so West and South West, have no mobile screening services, multiple static services, probably more than other parts of London, but no mobile at all. So where do you see kind of the swing between or the difference between the mobile and the statics, and is there a preference for either, and would you like to see more of them?
I think we would always advocate talking to the local population, you know, what is going to be the best way for them to access the screening programme. You know, anecdotally, a mobile unit gives you the opportunity to go to places where people already are and they feel comfortable. And I think that's talking to some of the points that we've already raised. Not having access to kind of that mobility means you've got less flexibility. So it's understanding where you can see opportunities to make it easier and more comfortable for people to attend. One of the areas that we've been sort of talking about and looking at is community diagnostic centres. Obviously, it's an area that's been looking at across different diagnostic tools. The breast screening programme is not often part of that, and that's an area that we think could be a real opportunity to think within a local community, where are those hubs that we're already creating, how can we co-locate breast screening within that, would, I think, be a good opportunity for us to exactly explore what's that good mix between fixed, so we know where people need to get to, but also being able to create new spaces where people can attend that are perhaps closer to home, more accessible, and you know, perhaps in areas where they feel more comfortable to attend outside of the clinical setting. But I don't know if you guys would have any additional thoughts on that.
Yeah, I think it's really important that we engage with grassroots organisations who understand the communities that they're in to really get the data. If those organisations aren't funded, then oftentimes when you have people coming from the outside who don't recognise who they're talking to or understand the nuances within those communities, then it can be shut down really quickly by the people who would benefit most from those services. So working with organisations who are already there, working with people like Outpatients, Black Women Rising, to really understand who the audience is and how you can reach them in the best way, I think is going to be really, really key to understanding how you can get better uptake when it comes to screening services. Having as many avenues as possible, because of course there might be people who, for a mobile screening unit, they're still not going to do it. There was one in Sydenham, Belgreen Sainsbury's. I don't think it's there anymore. It was there for so long. I would have never have thought to have gone in there. Whenever I looked at it, it didn't even look like it was open. So actually, are those mobile screening services being used in the areas that they are in? Of course, I can't speak to it because I've never used it, but every single time I passed it, it looked like it wasn't open or there wasn't anybody in there. It looked really sorry for itself, actually. So really understanding who in the community is going to be the best placed to help encourage people within that community to get the screenings, I think is really, really important. More so than perhaps saying, let's just put a mobile screening unit in there, because you need to know that it's going to be used. You need to know that it's actually speaking to the people that need it.
Thanks. Assemblymember Boff.
Thank you. Ms Dickens, is there any stigma from being seen to walk into units?
I think that's a really good question, and I wonder whether my colleagues on the panel would have some deeper insight from their communities that they work with. I think absolutely there is stigma around breast screening, around cancer, around all sorts of areas that we've been talking about. And I think you've highlighted that, there are barriers at every stage of this. Receiving an invitation, what does that mean? Why should I take this up? How do I get there? What does that look like? And, even into walking past a clinic and or a breast screening service and feeling actually that's not for me and I don't feel comfortable walking in. So I think there's a lot of interconnected feelings on that.
I think we'll probably cover some of that later on in the questioning, so thank you for that. There is one rather dry question I wanted to ask you. To what level is there private provision of breast screening, and are they recorded?
Again, that is a very good question that I think we'd probably need to come back to the committee with an answer on. Obviously, we've been focusing on the national screening programme. Obviously, from a private provision perspective, people who have private healthcare may well be accessing screening in different ways, but we can come back to specifics on that.
I'll tell you why I ask, because some of the lowest provision in London, and there may be other reasons, are areas of London where you would expect private health to feature more. That was why I've asked the question.
Yeah, no, I think that's a really good question, and if we do have any data on that, obviously we can come back to that and provide
Thank you
that.
very much. Thank you.
Thank you. Assemblymember Russell.
Thank you, and good morning, everyone. So I'm wanting to drill down a bit more into the invitations piece. We know that women over the age of 71 are not invited for screening, and yet when they are diagnosed, they tend to have those worse outcomes and be found at later stages rather than at stage one. So I'm wondering, Helen, if you've got any particular concerns about that.
Yes, thank you. And obviously the screening programme currently is set up so that those regular invitations do stop at the age of 70. And I think for us it's about understanding the evidence base of how screening can really support people to get that earliest possible diagnosis. And it's really important that doesn't feel like a cliff edge for women. That when those regular invitations stop, that they can still access the programme if they would like to, but also that they're really aware of their breast health and what they need to do if they see something that they want to get checked out. So I think that is an area that we would obviously want to make sure is really part of that awareness raising around the programme so that people are aware. One of the areas I think the panellists have already flagged today is around risk stratification on screening, and that's something that we've really been advocating for more research to understand how can we look at the screening programme and make it more targeted for people who perhaps might be at higher risk, and make it a kind of a more targeted programme. That's something that we know we need more research in. That's what we've been advocating for, and we hope that the National Screening Committee will be looking into that and taking that forward.
So just to be really clear, if you're over 71, you don't get routine invitations, but you can you still book yourself for NHS breast screening, or do you have to get it through your go to your GP with a particular concern?
My understanding would be that you could book yourself onto the screening programme, but you would have to be proactive at that. You wouldn't get the invitation through automatically.
And are women who reach 71, are they told that from now on it's up to you to book yourself in for screening?
I think that communication is definitely made. But whether or not that's something that is then kind of reminded, probably less so.
So it requires people to be very proactive about their kind of routine health. Yeah. You mentioned that a lot of the data is out of date, like people's addresses, their phone numbers and email addresses. So actually contacting people is difficult. And I'm wondering, do you think that's got worse since there's the private rental sector in London? So many people are living in private rental homes where they are often moving on every year or kind of at least every 2 years. And so that kind of connection with a GP practice may actually, may survive for 1 or 2 address changes, but doesn't necessarily survive beyond that. Do you think that's a factor? And do you think it's something that actually the NHS needs to be proactively communicating about?
I mean, I think definitely when we held a roundtable last year with providers of the breast screening service in London, that was one of the biggest challenges that they flagged to us, was that, we know that if you follow up non-attenders at their breast screening, or you can support people with more information through text messages and other routes, we know that increases uptake. But the challenge being that when they try to do that and those phone numbers are out of date and those the data is not there, makes it much harder. And I think obviously in London we do see people moving around perhaps more than they would in other parts of the country. That feels like a real driver of some of these barriers, absolutely.
Thank you. And I was going to come to both Lee and Leanne. So I'll come to you first, Leanne. You were talking about the need for more culturally appropriate materials, people seeing people who look like them on the invitation materials and information about breast screening. And I was wondering if you've got any sort of examples of good practice to share that we could be kind of trying to amplify and make sure get spread around more.
Thank you. So just to go back to your previous point about addresses and phone numbers and things like that, based on personal experience, having moved this year, how difficult I found it to get my information updated everywhere. Even this week, I went for my mammogram and they still had a previous name for me. And I was like, well, I've tried to update this and I don't know where to update it. So it's really a two-way street of getting systems to talk to each other. I just don't think they do. My MyChart might be updated. My GP still has got my old details because actually it's really difficult. I can't do it over the phone. I have to go in. I've got no reason to go in. So I found myself in this position where I know things are still going to my old address, which thankfully is 2 minutes down the road. But from this side of the table, it's really difficult to get it updated in all the places that need to be. So having a system that makes it easy for it to be updated everywhere would really, really help. In terms of representation and how important that is and good practice, Copperfield have a really great mechanisms for drawing in people. They tend to work with younger people who might need to look at breast checking and breast screening, but their diversity and representation, I think you'd agree, Lee, is incredible. They look at all sectors of the community of people who might need screening. And we often forget that men get breast cancer too, and there's hardly any information out there for men who might need to check their bodies and understand what breast screening looks like for them. So for me, great examples, Copperfield, of course, Black Women Rising, because we speak to our community, we speak to Black women and women of colour. Outpatients as well. You go to the communities who are already, go to the organisations who are already serving their sectors of the community, and you'll see when we look at bigger organisations, and I think Breast Cancer Now do a great job of it as well. I've been involved in many campaigns with Breast Cancer Now, but it's when you're trying to reach those small pockets who perhaps don't see outpatients, Black Women Rising, Breast Cancer Now, that we really struggle. So big, bold campaigns which really do show the sectors of the community that you're trying to reach to, I think, are going to be really, really important.
Yeah. And Lee, we did, this committee did a report on access to everyday healthcare for trans and gender diverse people 2 or 3 years ago now. And one of the things that we found through that piece of scrutiny was that data for trans and gender diverse Londoners is a real issue, and that the NHS systems that GPs have don't enable kind of correct gender markers or kind of any. Yeah, I mean, it just doesn't work for trans and gender diverse Londoners. So I'm just wondering if, in relation to sort of invitations, if there's anything extra that you wanted to say in that space.
Yeah, absolutely. The quality of data is a big issue because even though we do have both a sexual orientation monitoring standard, it's not really followed, and there's no good way to record that on systems, as you know. Similarly with gender identity, what we see in patient records is that sex and gender are functionally the same marker. So if it's changed, as you know, you lose the data. So this is more complex when it comes to breast screening because we're actually thinking more about people's anatomy rather than their sex assigned at birth. That's actually less relevant than what care they've accessed. Because you might have a cisgender woman who's had a mastectomy and she's not eligible, but you might have a transgender woman who's taken estrogen and she's eligible. So that's why the opt-in is so important, because we can opt out of the programme, we just can't opt into it at the moment, which is the problem. So I think that is the key adjustment that could be made to overcome that barrier, because we are just thinking really about practical eligibility questions with this one. And they are, as far as I believe, based on your understanding, Breast Cancer Now starting to stratify audiences within the breast cancer screening programme to be able to target things better. So it looks more optimistic that this can happen. So I think that's the key thing. The other side of it is the quality of information provision. If you look at the screening websites, the sections with targeted information, particularly for trans and non-binary communities, are much, much smaller, and they're very ambiguous about your eligibility. Part of that is that the actual research base and data quality to allow us to make very strong assertions about your risk if you're trans is somewhat not as good as we'd like it to be. We really need some more high quality research, and that's something we advocate for. But it means that people are making less informed choices about this and they don't have access to that quality of information. So we actually provide supplementary resources as a charity for our community. We're currently doing the second iteration of those. So we're going to be going out to do focus groups. A lot of people that come to those are Londoners just because of where we are. And we can absolutely share the outcome of that with you if you're interested in coming months. But that's looking at what do people need, what format do they want it in, what are their outstanding questions that they can't seem to find answers for. And that's the approach that we do see replicated across different communities that's had quite high success, whether that's ours, whether that's faith communities, whether that's different communities that might want those more targeted resources. So I think in terms of increasing that uptake, those would be the two adjustments that could be made for our community.
Thank you. Thank you very much. Thank you, Chair.
Thank you. Assembly Member Ahmed.
Thank you, Chair. Good morning, panel. I have to say that I've had a real sense of frustration listening to you all, and I'll tell you why. So I've worked for the NHS twice in my career, both within the equalities aspect of healthcare and how that can be accessed by different communities. And I'm hearing the same things now that I was hearing far too many years ago to remember. Why? I mean, so you've talked about different types of literature that don't represent the communities that they need to represent. We've talked about the going to where women go, going to where the target groups need to be. These are all issues that have been well established within the NHS, and that was done decades ago. What it feels like is if we're almost reinventing the wheel. And of course, what then happens? I mean, I accept that we have different communities. We have transient communities as well as people, and some of the communities that we have in London have changed over the last few decades. But surely the principles of how we access communities should are there should be the same, how we do that. So my question is, why are we still having this conversation? Leanne, would you like to start?
Why are we still having this conversation? It doesn't make sense. If we know all of this, who do we need to go to get them to change things? We can only do as much as we can within our organisations. Every time we go and speak to the NHS or we speak on panels, it's up to the people in those rooms to take away the information that we tell them and change things. Black Women Rising doesn't have the money to do it. Outpatients don't have the money to do it. Breast Cancer Now probably doesn't have as much money as needed to do it. The people who can make the change are the people who are asking us these questions. So it's really frustrating to repeat the same things over and over again. And we've got the cancer care plan coming in. So what is going to change? We're moving more towards community healthcare. But again, if the funding is not pumped into those communities, then nothing is going to change. So I think that's a really valid question. I'm not sure if it's a question for us, because we're doing everything that we can to make those changes. So who do we need to speak to? Who is actually going to make the difference? As we can say all we can say, but that's all we can do.
Don't worry, I will be raising this with the second panel. Lee.
Yeah, and just to speak to that, I think some of the people on the panel that you're about to have are actually fantastic advocates for health inequalities within their organisations. We actually see from our perspective that Cancer Alliances have been an incredible mechanism to actually foreground health inequalities. They're the reason why we could do our Best for My Chest campaign in North East London, which targeted our community. And that had a hugely positive response from the community in terms of increasing that confidence. So there are these mechanisms in existence, and there is that little bit of optimism there, I think, because we are seeing some steps forward. Of course, it needs to translate to that systemic change, but what we find as an organisation, and I can't speak for others, is that up to a certain level, we get very strong buy-in. You know, there are great inequalities officers at Cancer Alliances. ICBs often don't have an inequalities officer structure in quite as a robust way, so that's a question. How do you integrate that better? We also see that Cancer Alliances are sharing knowledge about tackling inequalities between them in a much more systemic way through their networks. But what we don't see is buy-in from national programmes, NHS England and DHSC. So if you look at the 10-year health plan, the inequalities, the named groups, it's socioeconomic deprivation and then a few mentions of other people. Cancer plan, we have written to them in partnership with both of your organisations as well and a few others to say we need named targets for inequalities groups, otherwise it just gets lost in this vague commitment. But whether or not we'll see that remains up as a question, and we'll find out soon, hopefully. So I think it's getting that national buy-in as well and advocating as far as we can up that chain to influence both local outcomes, but recognising that this is controlled by a national mechanism that needs to shift its perspective on inequalities and its prioritisation if the great work that some local teams do is actually going to be recognised and scaled, because there's this great innovative stuff that we see, but the buy-in doesn't tend to happen to get it taken up the chain. So I think there's also that kind of communication issue within the hierarchy sometimes, which can compound those challenges, and I'm sure you experience that in your own work as well.
Thank you. Helen.
Yes, thank you. I mean, I would completely build on that point around, you know, we know that there is really great work going on at a local level, and the teams that are looking to tackle these inequalities and to run a really great inclusive programme are doing what they can. And you know, and as we say, there are some really good examples of that. I'm absolutely no doubt you will hear that in the next panel. I think one of the challenges, again, is if that feels quite piecemeal, then you're doing something in one area, it works quite well, the funding stops or that post is lost and then something kind of shifts and moves again. We're not seeing that consistency, and we're not seeing that then scaled up and rolled out in a way that actually hopefully would mean that we've got really good sustainable programmes. I suppose one of the things that I would add to that is, you know, the screening programme is one of those programmes where we have to keep doing this, because actually there will be new women becoming eligible every year. It's going to be something new to them, and we need to keep making the case for it. It's not a done deal. It's not something we can talk about once and then leave. We need to be sustained. But I think one of the areas of opportunity that we should really think about is the neighbourhood health agenda. How does that really pull together those stakeholders locally to be looking at this in a joined up way? And how does that move into, as you were talking about, that kind of the national systems work, you know, the national programme, the screening programme, you know, the digital transformation that is being looked at there that will make the process and the systems and the data so much better will then have a knock-on effect to make this easier at a local level. But it really has to be that possibly can, and then let's be really focused and targeted to the communities that we know we need to work with on a local level. Where that works well, we can see real progress. I think the challenge is that we see progress and then we sort of change focus and then we come back to it. And I think being sustained would hopefully tackle some of that frustration that I think we all share as much as you have.
Thank you very much. Thank you, Chair.
Assembly Member Boff.
You know, it's very annoying when we get a panel here and they answer so comprehensively that it makes our questions, well, it just knocks all the questions out that we had. So thank you for that. The question I particularly wanted to ask, you've very fulsomely laid out what you're doing in the communities that you wish to support. I've got a question for you that's just occurred to me. I mean, Mick Stibbon, is the NHS nimble enough to be able to address those communities, or will there continue to be a role for yourselves? And the same question to Ms. Graham.
Yeah, I think there's always going to be a continuing role for community organisations to work in partnership, just because we hold the trust of our communities in a way that the NHS kind of can't as a large institution. You know, so particularly where the NHS is subject to political football a lot of the time and often becomes a focal point for a lot of issues, that can really damage trust in communities. So it often takes community organisations to be able to say, actually, we have great partners, we work with them, we trust them, we facilitate a lot of focus groups and co-production sessions in all of the work that we do to develop resources and campaigns. And what we find within those is that having us in the space as well can actually encourage people to get into the room. Otherwise, they just don't sign up. If you look at sort of your GP patient interest groups, right, they all typically are white and middle class and slightly older because they've got enough time to be on there. So what you can do by bringing community organisations is actually diversify the audiences that health bodies can engage with. So I think in that sense it will always be essential. Also because communities change, right, quite regularly. Particularly in our community, we see a lot of flex depending on age, depending on how people identify. And to expect NHS bodies to hold that knowledge is quite a big ask, to be honest, particularly where they're trying to address all these inequalities. So I think that has a sustained role.
Ms. Graham?
Yeah, I agree with everything that Lee has said. There will always be opportunities for the NHS to work with community organisations to really get the best out of the information from the top and the bottom and bring it together in the middle. I think if you stop working with community organisations, you will see a drop in people who are going for their screenings because they will start to miss out on where the information is coming from, the route of getting in the NHS information to those communities. And I think that's, yeah, I think it's really important that we just continue to work together and make sure that we're all giving the same messaging and the right messaging to the people that need it.
Thank you. Thank you, Chair.
Thank you. Assembly Member Wilson.
Thank you, Chair, and good morning, panel. So the question I'd like to ask is a slightly different one. So I think we've talked quite a lot already about kind of access to screening and uptake and all that sort of things. My question is more about what might happen once you're actually there and how that process can be transformed. And it's about AI. I mean, we've heard a lot. We hear a lot about AI as being a tool that can be potentially, transformative in many good ways and, some slightly concerning perhaps. But in this kind of area, just interested to understand, what role the growth of AI could play in speeding up and making more accurate the results of screening programs, and then with that, obviously, freeing up the clinical specialist time to then focus more on treatment as well.
Yeah, great, and thank you for that question. I think AI is something we're talking about a lot. I'm sure many people are as well, and we know that the focus at the moment, looking about research into AI and how it could benefit the breast screening programme has been largely focused into that point that we are then looking at the mammograms, the outputs of the screening, to really understand how we can speed up and make more accurate that process. So Breast Cancer Now, we've really welcomed the recent commitments to investment into that research so that we can really understand the potential for that AI technology to be able to, one, speed up that process to free up kind of clinicians' time, but we also want to make sure that it's being used as safely and responsibly and ethically as possible. And I think that is why this research is going to be so key. One of the things that we know about any kind of AI process is that it's only as good as the data that gets fed into it. And so what we're hoping through the research is that the AI tools that are being looked at will absolutely be trained on really the kind of the largest diverse range of imagery that it possibly can, because as we've talked about, there are an incredibly diverse range of people who are screened through the programme, and we want to make sure that there are no risks of bias, no risks of things coming in that would make it less accurate. We want to see how this tool can really speed up and make more accurate diagnosis. So that research is going to be absolutely key. And we're waiting to sort of see how that gets set up and how that's used. I suppose one of the things from our perspective is we want to see that done as quickly as possible. We know these things take time, but actually we want to be seeing that research come through as quickly as it can. But for the screening programme itself then to be really ready to take that on board if we do see that there is benefit from AI supported screening tools. And that staff members are obviously then trained to be able to use it as well. I mean, there are some examples, I think, of work going on to look at how can AI also help in that kind of risk stratification and invitation to screening and the uptake barriers that we've talked about today. Again, I think that's at quite an early stage. We would say absolutely, we want more research into all of those different areas. So make sure that any use of AI is not taking away from that kind of human important touch that we've all talked about, and that it doesn't embed any further inequality, that actually we're using it to break down those barriers and tackle inequality. So I think it's a cautious, if it helps us, then absolutely we should be using it, but we really want to understand that evidence base and make sure that it's being done in a really effective way.
So are there any sort of early indications from what's happened so far that is going in the right direction and it's going to be, or are we still waiting for sort of outputs? Because I think the trial started just under a year ago, so I don't know, is it too soon to know what it's giving up yet, or do we have any kind of early thoughts?
Yeah, I mean, we certainly haven't seen any outputs of that research yet, and we, expect it to take a number of years to get to a point where we're really clear on what those outputs are. As I say, there may well be local pockets of activity going on around how people are using it within their local programmes. That would be something hopefully we would start to see over the next few years.
Thank you. I don't know if anyone else has any comment on that, or if not, then back to the chair. Thanks.
Doesn't look like it, so I think that's
okay.
Thank you very much. Assembly Member Harani.
Thanks, Chair. So just an open question really about the government's forthcoming National Care Plan. So what would you like to see in the plan that hasn't been mentioned already? So I think I'll start with Helen to my left.
Thank you. We're probably going to say a lot of the things that we've already said, so I know I definitely will. Obviously, we're really looking forward to the National Cancer Plan. We've been feeding into it as organisations and across the patient advocacy groups, really to see this plan as a kind of transformational moment in how we diagnose, treat cancer and support patients with cancer. Specifically around screening, we've talked, or I've definitely talked today about some of the challenges we know we have with the screening programme and the sort of the digital transformation piece that we know needs to happen. I think we would really hope to see within the plan, specific commitments around making sure that we are really seeing that digital transformation to the system so that we can increase the convenience and flexibility of booking in screening appointments, that we've got really good data on inequality so that we're using that really to tackle some of the barriers that we've talked about today, that we're able to see kind of updates in how we're talking about and raising awareness of screening. But I think it's really also looking at how we make sure we have that national monitoring and evaluation framework in place so that we've got really good accountability at all levels. So we've got accountability at a national level to make sure the screening programme is performing as it should, that there's really good support at a regional level to make sure that regionally, within all of the different routes that we have the support and accountability to check that things are working, and that there is good resourcing there to enable us to achieve all the things that we've talked about today. So some of that might come through the neighbourhood health agenda, some of that might come through the moving of commissioning to the integrated care board, but actually it's about making sure we've got accountability at every level of the system. So we are hoping to see commitments around that as well.
Lee?
Amazing, thank you. Yeah, so I already mentioned one of them, which is that we are hoping to see clear targets and outcomes for named health inequalities target communities, particularly covered under the Core 20+5. We are hoping for a recommendation for a breast screening opt-in update, so that's the one I've been speaking about a lot. Beyond that, we would really like the recommendation for mandatory training on culturally responsive care across health inequalities. We see that often that's integrated into CPD, but it's usually driven by passionate individuals, which means a very patchy uptake. It's also informed by self-selection bias, so we may not reach the people that need that training the most. More broadly, when we're thinking about cancer, we would really like to see better data collection on sex, gender and sexual orientation to allow for approaches to cancer that actually have a better data set and allow us to make those informed choices and recommendations. And then finally, we really want to see the uptake of more culturally informed patient-reported outcome measures, PROMs, and PREMs, which is patient-reported experience measures. And they're really key ways of measuring people's experience within healthcare settings. But we want those that are culturally responsive to capture identity-based experiences because they're often quite generic, and that means that we often lack that detail that could really be beneficial in addressing health inequalities. So there are kind of 5 big dreams, and we'll wait and see.
Thanks. Leanne?
Many of our wants for the plan really match outpatients and Lee's wants there as well. Collaborative is a really big word. Collaboration is a really big word for us, and we want to be able to work with the NHS and the government to make sure that the expertise within our organisations is used, is listened to, is heard, because we know the people that this is going to affect. We work with them every single day. So using us and our expertise and helping us to expand our reach is going to really, really help those patients who need the support from the plans. Understanding the technology and making sure that people are adequately trained on it so that we are using it responsibly and we are using it in a way that is intended, again, to just really get that reach, and understanding the demographics of the people that the plan is not going to reach and making sure that we get into those pockets of the people that we don't want to be forgotten. So I think those are some of the key drivers for us.
Okay. And just on the changing in terms of commissioning of the screening programme from April 2027 to the ICBs, so just a question really on what changes you'd like to see when that change happens and you see ICBs in London take over the commissioning. So I'll start in reverse order, maybe from Leanne.
That's something that I'd have to speak to the team about and come back on. I don't have the answer immediately for that one.
Sure. Lee?
For us, it would kind of be the maintenance of relationships. What we find as kind of community organisations is that we build strong relationships with people, but due to the mergers, workforce changes that happen often when these things occur, they can be lost in that process, and therefore the NHS can lose the expertise of those community organisations who they've been working with for years. So I think for us, the key thing that we hope to see is the maintenance of those relationships, perhaps the development of new relationships, and also those ICBs drawing on expertise from people like Cancer Alliances. You've got some fantastic ones across London who are really ahead of the game on health inequalities and tackling low uptake across different areas of cancer. So hopefully they can work in more collaboration in that sense too.
Yeah, and I think that word collaboration is really important, isn't it? Because what we would hope to see that this is a real opportunity to reduce some of the fragmentation of work going on around, breast screening as we're talking about today, but some of those broader health inequalities work. I think we see that as an opportunity under the ICB banner to bring together those different functions and to be able to see that cross collaboration. I think there's a risk that we lose the great work that's already being done. So we absolutely want to see that continue, particularly those relationships with Cancer Alliances. But for us, it would be an opportunity to bring in all those different functions across the ICB patch to look at where those different touch points are from a kind of public health point of view, as well as the breast screening point of view. So that would be our hope from the move. And again, as to echo colleagues on the panel here, I think as patient advocacy organisations and as community organisations, we want to stand alongside the work of the integrated care boards to make sure that we are also seeing those patient voices come through to the fore.
Okay, and do you also see it as an opportunity to better tailor services to local communities? Yeah,
yes, absolutely.
Okay, thank you.
Thank you. I just wanted to check, did you all put in formal representations to the consultation on the National Cancer Plan? And obviously that was expected late last year and it hasn't. So as formal consultees, have you heard anything more on a publication date or reason for delay, or there's not been any feedback?
I mean, we understand that it is to be published soon.
Okay, all right. Thank you. Okay, with that then, can I just thank you all for your time today? That's been a really interesting session and a great way to open up. So thank you so much. We're going to move on to our next panel, which is more of the NHS specialism panel. We'll take a 5-minute break and be back here at 11:05. Thanks. welcome back to the Health Committee, to our second panel of guests. Could I welcome Dr. Josephine Rwende, Consultant in Public Health and Cancer Screening Lead from the NHS London Region, Zara Gross, Programme Manager for Early Diagnosis South East London Cancer Alliance, and Dr. Will Tay, Consultant Radiologist and Director at North London Breast Screening Service. Thank you so much, all of you, for making the time to be here. And Josephine, perhaps if I could start with you and move this way along. Why, in your opinion, does London have one of the lowest uptakes of breast cancer screening in England?
It's a complex mix of various factors. We see that uptake or participation in breast cancer screening has an association with deprivation or social economic status. So people who are more deprived are less likely to attend breast cancer screening. And we also see that people from ethnic minority groups or minoritized groups and people from certain religious minority groups like Muslims, Orthodox Jews, and so on are less likely to attend. But the biggest factor that we see in London, in addition to the fact that in areas where you have greater socioeconomic deprivation as well as greater ethnic diversity, is the impact of population churn. So this is people changing addresses. So if you change address and you don't update your GP, this then affects the invitation process, because GP details are then used to identify individuals who are eligible for screening and then send them the invitation. So in our London boroughs, particularly in inner northwest London and the other central London boroughs, we have the highest population churn of any local authority in the country. So we find that this is strongly associated with the lower uptake and coverage that we see in London. But you also find that in these boroughs, whereas generally when we look at a national level, you see this inverse association between economic status and breast screening attendance. But you'll find that in London in particular, the most affluent boroughs have the lowest uptake. And that is because in some of these boroughs, you have very, very high population turnover. So people are changing up to 40% of the population can change addresses within a year. But also you have in some of these affluent boroughs, a significant proportion of second homes, people spending significant parts of the year outside of the country. So it then becomes quite a complex mix of the NHS not having accurate details of individuals. So they are sending addresses to the wrong, sending invitations to the wrong address, or sending people invitations when they're actually out of the country. So that, I'd say, is are three reasons why London has the lowest uptake. And before I conclude in terms of that question, the issue of population churn also affects the GP, the size of the GP list, and which means that our GP lists are highly inflated. So we think that in London, in certain boroughs, our denominators are not correct. So the number of eligible women in northwest London and some central London boroughs is actually smaller than what is reported nationally, which means that our reported uptake and coverage could be higher than what we see in the official statistics.
Thank you. And Zara?
I can just talk for South East London, but we have a wonderfully diverse population in South East London, and we do see, in terms of uptake, it varies depending on ethnicity, like Joe has said, and also when you look at deprivation as well. I think there's also, we also need to highlight the fact of there are particular groups within our population whereby screening uptake is particularly low. So when we look at patients with learning disabilities, patients who have SMI, so serious mental illness. So there are various factors, and it's multifaceted. But I think, Joe's covered a lot of that. But in South East London, we do see that in terms of the data and in terms of ethnicity and in terms of deprivation status, you do see uptake drops significantly when you look at the areas of highest deprivation compared to the lowest areas of lowest deprivation.
Thanks. And that was something that I was just talking about. I found really interesting, though, is when we were looking at uptake, You've got boroughs like Kensington and Chelsea with some of the low uptake, and that seems to tally with some of what Joe was saying about the maybe people being away or for work, or that's not their first address, so they're not being screened there. But those deprivation indicators we normally look at with health, it doesn't seem to correlate necessarily or 100% in this instance.
No, I mean, Joe is the expert in terms of looking at other boroughs. I can just say for South East that, you know, we know the challenges that people face in terms of areas of high deprivation. We know that lots of people are on 0-hour contracts. We know that actually employers don't allow them to go to a screening appointment because they take place during 9 to 5. So we know that there are challenges. And I think, you know, there's lots of great work that's happening across London in order to support our populations and also highlight the benefits of screening, especially with our populations in areas of highest deprivation.
Thanks, Will.
Most of it's been covered. So if I speak for North London, for instance, we find that the inner city areas are, even within our same service, will have a lower uptake, and that those are the areas we need to target. For instance, Camden Islington is low. If you look at areas of Barking and Havering, and we actually do also screen London's sort of West Hertfordshire areas, their uptake is incredibly high. I mean, they exceed the 70% that we need. Whereas in Camden Islington, it's well below. You know, we struggle to hit 60%. So there is definitely variation by region, by boroughs, by deprivation, by population, even though it will be the same screening sites that people will access.
Thank you. Assemblymember Harani.
Thanks. I'll just start by probing that a bit more, because that doesn't necessarily correlate to states in those parts of London initially linked with high levels of deprivation, given some of the areas you've mentioned, but also maybe I'll turn to Josephine on this one around why uptake is significantly lower within those sort of inner London boroughs.
Yeah, so I was making specific reference to the inner London boroughs that are relatively affluent in comparison, so Kensington and Chelsea, Hammersmith and Fulham, and so on. And in terms of the uptake of public health programmes, this is consistent across the board, that these inner northwest Londons have low rates, the lowest rates in the country, of bowel cancer, breast cancer screening, cervical screening, and a lot of the immunisation programmes. And I think it has to do with the issues that I have mentioned around population mobility, people opting for private health care. So for people, you know, in their 50s and above, I guess, with, I guess, a higher income, they may opt to have private, you know, screening. And I think this is explains the anomaly in London. I think if you were to take out those affluent inner northwest London boroughs, and you look at maybe the more traditional affluent, the Kingstons, Richmonds, Bromley, you see that they do have the high uptake that you expect, and the uptake and coverage is very similar to West Hertfordshire or to other boroughs or areas outside of London. So there is something very specific about second homes, the use of private healthcare. Yeah, and yes, and I guess population churn.
And how would that work? How would that work then in terms of so if someone has been screened using a private service, but then had a diagnosis of breast cancer, would they? So would that come into the numbers and the figures that the NHS see? I mean, regardless of where they have their treatment afterwards, how does that work? Because what we're interested here in is sort of the whole population health as well, and how that is working in London.
So I can pick this up, but maybe Will may want to come in as well. In terms of screening that's not done in the NHS, it doesn't count towards our official statistics, whether it's done in the UK or outside of the UK. And this is because the NHS cancer screening programmes are quality assured to a very high standard, and the NHS is not able to quality assure screening that's done elsewhere, even when it is within the UK.
Okay. So there are two aspects to a patient who's diagnosed with breast cancer outside the screening program invitation, firstly, obviously the figures do not count because they are not the cancer diagnosis is not an outcome of the screening itself. So it becomes an interval cancer. However, because we have a very good cancer registry system, the cancer diagnosis is logged. And therefore, we have a very robust national system where we will correlate all the cancers in the screening age group who have been detected through the screening route, as well as those who haven't. So we have a complete picture of all the breast cancers that has been diagnosed, both private, within NHS symptomatic clinics, or within screening. So we've got those figures.
Okay. No, thank you. That's very helpful. And just turning, Josephine, to some of the questions that we asked in the first panel, and it would be interesting to get your views on the low uptake on screening. Now, one of the speakers mentioned that obviously the earlier you diagnose, the quicker people can get to treatment, and if you detect at an early stage, then the likelihood of success is far greater. So is the low uptake leading to worse outcomes for Londoners and later diagnosis?
From a clinic, I think that's maybe a clinical question. Well, are you okay answering that one?
Sorry, I missed the question.
So the fact that we've got a lower uptake in London, and from the first panel we heard obviously that if you detect cancer at earlier stages, then likelihood of success is greater. So naturally that leads us to suggest that if diagnosis is coming later, then the cancer has obviously progressed in a far worse state. So is the fact that we're having a lower uptake of screening in London generally leading to worse outcomes for Londoners?
Well, in theory, it should do. Fortunately, we have got a pretty good two-week wait system, but there is very good data, as you say, really from published papers from screening, which shows that, including the UK, where the non-attenders, the ones who never attended screening, as well as the lapsed attenders, those who do not attend regularly, do end up having a later stage of cancer detection, and therefore, yes, there is a knock-on effect on outcome and prognosis.
Okay. Great. It'll be great to see if we can get some of that data around whether people in London, when they are first diagnosed, are coming in at stage 2, 3, 4 rather than stage, and how that compares to the rest of the country, because that will give us a bit more evidence in terms of the impact of the low uptake in London. I don't know if that's something that you would have data or access to.
Yes, there's actually a publication by NHS Digital called Routes to Cancer Diagnosis, which has this exact data. So very happy to share it with the panel.
Thank you. Thank you. And just parking aside the 2025 breast cancer awareness campaign, which one of my colleagues will ask more detailed questions on, but what other action is the NHS taking to increase uptake of breast cancer screenings?
So we've been, as an NHS, we have been working to improve the uptake of breast cancer screening and reduce inequalities for many years. A lot of the research into inequalities and the behavioural factors that influence people's participation in breast cancer screening have actually been done by London academics, a lot of it where the NHS have been collaborators. So our work over the past, I guess, 10 to 13 years as NHS England has taken, I guess, three main areas of focus. One has been creating the insight and the evidence, so the insight as to why people don't attend, which people don't attend, and what interventions work. And one of the key research that was done, I think possibly about 10 to 12 years ago, was the importance of text reminders and how these can increase participation, and they actually can increase participation to a greater degree in groups that are more deprived. And London was very early to translate that research into practice. So since about 2016, 2017, we were the first region to implement text reminders in the country. Now, in addition to supporting research, and that is just but one example of the work that we do in partnership, is trying to address the behavioural and the structural barriers to screening. So we know that some of the behavioural barriers are, people forget. They can forget their appointment, and text reminders does address this. But in addition to this, understanding that there are factors like fear and stigma, embarrassment that stop people from attending screening, and as a result of that, we did co-invest as a region in the National Breast Cancer Campaign, which actually had an upweight in London. So there was more investment in terms of media and community engagement in London. But also all of our breast screening organisations now have a very clear and specific role around promoting breast screening and addressing inequalities, and they each have a health promotion function, and they actually have staff whose role is to identify key communities that face particular barriers to screening, whether it's knowledge and so on, and whole community engagement events, and they also support primary care in terms of strengthening their role in terms of attendance. But possibly one of the biggest things that we did as a region in about 2016 was a reconfiguration of the breast screening services to form a single breast screening administrative hub. And this has in essence made breast screening more accessible across London, and Will is also the clinical director of the breast screening hub. Because what the breast screening hub provides is a single call centre for all of London. So if in London you want to change your appointment, or if you have any questions related to breast screening, there is a single phone number. There's also a single website if you need to change your appointment. The breast screening hub, in addition to having a website and a call centre, they do actually enable women to be screened anywhere in London. So whether you live in Richmond, you can be screened in Barking if you so wish. But also they have brought together expertise around breast screening management, breast screening administration, and also strengthened capability around data and analytics. The committee may have seen a health equity audit that I shared a draft, and this is because of the very unique data that we have as a region as a result of having the London hub. But Will may want to add to that question. Thank you.
Thank you. Yes, certainly London hub is quite a great model, because this is only one that exists in the country. And it's actually because there's always resilience in numbers, as opposed to 2 or 3 people manning the phones, for instance. Each single breast screening service we run if you like, the appointment system for the whole of London, which means we can open 7 days a week. We can, the average wait time is 30 seconds. We've got multiple booking options. They can call by phone. They can do it through email. There's an online booking service, and then next year, or coming later from April onwards, we're planning to introduce live chat. It also means that we can introduce kind of London-wide DNA initiatives, calling people out of hours, which normally, most NHS services are 9 to 5 in terms of calling, and Monday to Friday. So we are doing this as well. There's a standardized approach. We standardize this 4 weeks ahead. We've got text messaging 7 days ahead and 2 days ahead as well. And we have DNA letters that we send out as well, twice. And we work with the Cancer Alliances, the ICBs, NHS England, GP practices, and community services across the board to provide them useful information about data, and also to work with them in terms of what they might want to achieve at the local level. So that's a whole lot of things that we are not able to do as a disjointed 6 services across London that we're able to do because we have the size and the manpower to do it.
Thank you. It sounds like a model that I think other parts of the NHS can copy, really. So just a final question from me, because just looking at the services, the screening services that are around London. So in some boroughs you have, or some areas you have static as well as mobile, and in some areas static only. Is there a difference in uptake based on what's available in local areas from the static versus mobile? Oh, maybe, yeah.
That's a very interesting question. The two things about static and mobile, so I mean, there's a tendency now to try to move towards static services. The reason for that is where you've got good public transport links, static is usually the way to go, because we have always, because we have a mixture, the services in North London, in particular more than South London, have to run a mixed static and mobile service, because we serve areas where public transport is not really accessible. People have to drive. And we always find every single year more and more difficulties in actually parking our mobile in a particular place. They're very large. They need a particular type of power supply. They need the water supply, and the power supply is not just a 3-pin plug you plug in. They're actually they're probably not dissimilar to what the EV plugs that you need to the higher wattage ones. With the drive from NHS, NHS Properties, TfL, and everybody else around, they're investing from property. So where we found previously we have enough space, because they're very large, they take about 8 parking spaces. Every year we find that the place we used to park has been sold, the land's been sold. We can't park there, or where they're willing to have us there is a time limit, and they haven't got the power supply, so we've got to put them in. So increasingly getting somewhere with the drive towards less parking spaces, even, and still a property, because people are short of funds to support their own businesses. Places that we can go to are becoming increasingly restricted, because we're not supposed to have parking spaces anymore. So we're going to find 8 parking spaces to put a mobile van. Having said all that, there are huge advantages as well to static sites. They're inside, they're dry, if it's raining, you don't have to be waiting outside. There are usually toilets nearby, and you can keep warm. There's usually a cafe. So wherever possible, static sites are definitely preferable, and people can usually get to them. And for instance, in North London, we recently converted a mobile site. We used to go to Northwick Park to a static site inside, and it's great because they can come in, it's dry. Whereas before, we had to park next to a cemetery, the crematorium, and now of course we can't park there anymore anyway because the land's been sold. So, but we understand the need for mobile spaces, but it's a real challenge.
Okay, thanks. We're going to have to be a little bit more speedy on time now, but Assemblymember Russell.
Thank you, and good morning, everyone. I'm just wondering on those mobile spaces, you'd have thought that every local authority would have space maybe near their town hall or somewhere where there would be access to power and a number of parking spaces. But yeah, that's really worrying that all the places where you used to, because if people are used to going to a mobile facility, then that's a shame if that's no longer possible. Anyway, my questions are about the 2025 breast cancer awareness campaign. And we heard in the first panel about some of the work that's needed around reaching out to trans and non-binary Londoners for screening, and also the urgent need for culturally appropriate materials so that everyone in London who's eligible for screening feels that they see people that look like them on the materials. We also heard that it was all a bit too pink for breast cancer screening, particularly for trans and non-binary people. So my sort of first question is sort of what's your view on the impact of the 2025 breast cancer awareness campaign that happened in London last year? Zara, I just saw you writing some notes, so do you want to go first?
I was just writing notes about what we have been doing, because I think what's great about the large-scale campaigns is that we work with NHS England. So I'm part of a Cancer Alliance, one of 4 in London. So we work really closely with NHS England when there is a large-scale campaign. But that only reaches so far. And I think that's where Cancer Alliances, along with other partners within our areas, work really well. So I've worked with Outpatients, we've worked with Black Women Rising around actually how can we support our communities that don't come forward for screening. And I think what's really important is that, number one, you listen to the communities that you're working with. So the charities that were on the panel, in the first panel, they are the experts. We're not. So it's really important to work with the community groups, and I think that was really important. So not only do you have this large-scale campaign, but you also work with the communities within your different areas to make sure that the campaign is fit for purpose for them. And so that's what we did in South East London. So we have got, as I've said, we've got a wonderfully diverse population group in South East London. We have a high proportion of Black African, Black Caribbean women that are less likely to come for screening. So it was about working with them, ensuring that actually we understood the barriers and we understood actually the levers to ensure that they would come for breast screening. And that was very much around working with community groups that are already set up within the various boroughs in South East London, but I know this happened across London as well in the other alliances. So it's about working with communities. Jo can give updates and data around kind of the impact of the large scale, but I think that's really important. You can't just do a large scale campaign. You also have to work with the community groups that you have within your geography.
Mm-hmm. So you worked with sort of in relation to that NHS campaign, but you were doing that deeper dive of deeper community engagement.
Yes, so we were really lucky. So we've worked with an organisation that NHS England has worked with on this campaign. So we had a lot of insights around what worked and what didn't. And we know from our fantastic data around uptake and looking at uptake across various population groups that we know don't come for screening, we worked and used those insights to support the larger scale campaign that took place in 2025. So working with the organisation that supported the campaign and worked with them to engage with those populations and really targeted those populations that we know don't come forward.
And was there monitoring of the input that you contributed to the campaign?
Yeah.
I mean, do you have data that kind of says, about that impact of that whole overall campaign and then the bits of work that you did to contribute?
We have local data that we can absolutely share that looks at the impact that depending on the time range of what particular campaigns, the impact they have. Obviously, with any campaign, there are other projects, there are other interventions that are taking place, but if you see a significant increase, you can attribute some of that to a large-scale campaign. And we also, with things like this, with working with the community, it's more around the qualitative information that you get from the community, the insights that you get from them, that we have and we can absolutely share with yourselves. Because I think it's really important for learning in the future.
Yeah. So just to be really clear, is there data then that shows that kind of deep community engagement that came through your contribution to the overall campaign, that makes a difference?
I believe so, yes.
Yeah, fantastic.
Yeah.
It would be great if you can share anything
That's
you can.
absolutely fine.
Josephine, did you want to come in?
Yes, so as I mentioned previously, the national campaign had a strong upweight towards London. So there was additional investment in terms of media in London, TV, radio, video on demand, and social media. And in addition, there was a big investment in London for out-of-home advertising. So only in London did we have the breast screening campaign running on the London buses, particularly running in routes in areas where we have low uptake. So the national campaign had a big multicultural element because the priority groups, in addition to being younger women, so women in their early 50s, it was also on ethnic minority women who are less likely to attend. So in London in particular, we worked with an organisation targeting minority groups in the boroughs with the 10 lowest, the 10 boroughs with the lowest breast screening uptake. And this involved having female-only street teams going to a variety of areas within the locality, jointly identified by the local authority, where women are likely to congregate and having discussions about breast cancer screening. And they also attended events to speak about breast cancer screening. And as part of that multicultural campaign, there was a PR element where they had minority influencers and celebrities and healthcare professionals across social media, on community radio, on certain minority publications like The Voice and so on, talking about breast cancer screening so women can see people who look like themselves promoting breast cancer screening. So we have an evaluation from the London Community Engagement campaign, which I did share with the panel, and apologies for the late circulation of that. And it showed that the reach was actually quite extensive. Altogether, they were able to reach close to and have one-to-one conversations with close to 30,000 women. And I think it was 10,000 women in terms of one-to-one conversations, but at the events, I think they were able to reach 30,000 women. And they also sought feedback and surveys, this organisation, on the materials themselves and the messaging, and that was overwhelmingly positive. And they had 100% take-up of their materials when they were on the street. Every single person who they offered to materials to took up the offer, and these materials were actually designed. Were actually designed in London by Londoners. It was a collaborative effort in designing those materials. The wider campaign, including the London Upweight, the evaluation is still in train, and this will include a pre and post campaign analysis of the impact on people's knowledge, awareness and intention to attend screening. So we don't yet have that data, but also very importantly, that evaluation is going to look at the impact on screening attendance pre and post the campaign. So as soon as that is available, I know that the data is imminent. We are very happy to share it with the committee.
Fantastic. There's one group that hasn't been mentioned in terms of that NHS campaign, which is trans and non-binary Londoners. We have a disproportionately high proportion of our population are trans and non-binary in London, and I just wonder whether there's any recording that went on in that campaign about participation by trans and non-binary Londoners.
I'll have to come back to you on that. I think there possibly was, and there was material that was distributed via social media, but I'll have to confirm that and come back to the committee.
That would be really helpful. Thank you. And then, final question. Do you think the NHS will run campaigns like this again in the future, sort of taking a big focus on breast cancer screening, and do that same kind of big campaign that you did last year?
I'd like to hope so, but the NHS is, or the commissioning part of the NHS is at the cusp of quite significant change. So I couldn't say what the capacity, the capability, the appetite would be, definitely in the near term as we're going through these changes. But having run various large campaigns in London and been part of big national campaigns, we definitely see the value in London. These campaigns, particularly when they are both, the big media on the buses, on TV, combined with the multicultural element and the community engagement, are significantly impactful. And we have data from our bowel and our cervical screening campaigns in London that we do actually not only increase people's awareness, but we do actually get more people through the door. And this is particularly important for younger people who are coming into screening for the first time, because if you do take part in screening once, you're more likely to take part in screening, into your later years. So we would hope that these campaigns do continue in London, where we have the lowest uptake and coverage of a lot of these screening programs.
Thank you. Zara?
Yeah, just on Joe's point, really, I think even if we don't see a large-scale campaign across London, you have 4 cancer alliances that are dedicated to improving breast screening uptake. And we all work with system partners. So we work with charities, we work with public health, we work with NHS England. So I think even if we don't see a large-scale campaign, what we are very good at is sharing resources, sharing insights, and working with voluntary sector organisations to really focus on our population groups that don't come forward and really understand and think about how we can support them.
I think there's going to be questions about that coming up from just a little bit further. So I'll pause that there and hand back to the chair.
Thank you. Assembly Member Wilson.
Thank you, Chair. My question is sort of following on from the discussion about the big national campaign last year. But one of the things that you mentioned was adverts on buses. Do you know, did you have to pay commercial rates to have those adverts on the buses, or was the Mayor and TfL helpful in getting that message on there?
I couldn't say. If the information is not commercially sensitive and I'm allowed to share it to the committee, I can go back and find out.
I think that would be helpful, because the final panel that we're having on part of today's meeting is obviously looking at what exactly the Mayor and TfL can do to help with important public health advertising campaigns, and I was wondering if this was one that there had been some help already or not. In your view, what do you think the Mayor, TfL and kind of London government more generally could do to make it easier to share this kind of information, whether it be through a big campaign, the likes we've just talked about, or just more generally? And that's open to anyone, please. Thank you.
With our campaigns that we've run in London, we've gotten quite a lot of support from local government, from our directors of public health and our local directors of communications, from local authorities. So we have worked very well in partnership in terms of them amplifying our campaigns, sharing, using their channels to share campaign materials and so forth, and identifying key areas of community engagement. And it would be helpful, if we could have a similar mechanism by which we can work with the Mayor in terms of amplifying our campaign using the Mayor's channels or the GLA's channels. And I think, as you have mentioned, if there are preferential rates around using TfL space, London buses, or roadside advertising and so on. But I suppose it would be helpful if in the Mayor's role around promoting the health of Londoners and in his health inequalities strategy, he highlights the importance of these preventive programs like immunisation and cancer screening. I think immunisation is a relatively easier sell because, it's young people, it's babies and so on. But cancer screening, these are the most effective programs that we have. They have been around for a long time, and because in London our uptake and coverage is low, we don't necessarily see the public health benefits of these programs. So anything the Mayor can do to raise the profile of these highly effective screening programs would be much appreciated. Thank you.
Thank you. Zara, do you have anything to add on that, please?
No, nothing. I think Joe's covered it.
Okay, and I guess not from you either then. In which case, back to the chair. That's a really comprehensive answer, and I'm very grateful for it. Thank you.
Thank you. Assembly Member Boff.
The NHS did a review of about tackling health inequalities experienced by LGBT plus people. Do we know if that's complete yet, Dr. Rwande?
I'll have to come back to you on that one. I'm not aware.
It probably isn't then. Otherwise, in which case, I think that question is pretty much already answered in previous.
Thank you. Assembly Member Ahmed.
Thank you. Good afternoon, panel. I'm going to ask you about the national reforms. So, first of all, can you tell us when the plan is going to be published? It was meant to be in 2025. We still don't have it. Does anyone have an update on that, please?
Which plan is that? The National Cancer Plan?
Yes.
Okay.
Sorry, apologies. Yes, the National Cancer Plan.
So it's going to be published on the 4th of February.
Right, lovely, thank you. So what extent will the government's National Cancer Plan seek to address the uptake of breast cancer screening in London?
So unfortunately, because we are so close to publication, we're limited in terms of what we can say in advance of the official communication and release by the Department of Health and the NHS. So I'm afraid I can't answer that question. I apologise for that.
Okay, that's fine. Therefore, I'm assuming that nobody else can give an answer to that as well then. Thank you. So moving on to the commissioning powers. So could you tell us what progress has been made in transferring commissioning powers for the NHS breast cancer screening programme to ICBs, please? Anybody could answer that.
So the provisional date for the transfer for the delegation of commissioning responsibilities is April 27, and this is subject to the appropriate changes in legislation. But in the meantime, there is work undergoing to review which functions are transferred to ICBs, and it is anticipated that screening will be delegated to ICBs. So there is quite a lot of work that is ongoing, including joint working with the ICBs and the NHS in preparation for that, which includes joint planning around some of the key strategic plans that are in train, understanding of service configuration, performance, and joint working in preparation for that.
How can you anticipate how the transfer of those powers will actually impact the programme?
I think it will be positive. So I started working in public health in a PCT, and we used to commission breast cancer screening. So PCTs had a similar boundary to a local borough, so significantly smaller than ICBs. But the value of local commissioning was that services, by and large, and pathways were designed with the needs of the local communities, but also taking into account service provision, and service provision then being adjusted to meet those needs. So I can see the benefit of aligning strategic commissioning closer to where services are and where and where the people are, or where the patients are. But there will be, I think, some functions, particularly those that are delivered at a national level, that possibly should be retained at a national level or commissioned at a national level. So quite a lot of the IT systems, for example, that support our screening programs are NHS-wide, so they wouldn't be commissioned at an ICB level. But by and large, I think the the programs themselves, the clinical services, should be, we'll see a lot of benefit by being commissioned locally. But Will may have a view, because I know you've been around for a while as well.
Yes, I think I always find it rather unfortunate that we always get sort of changes in kind of commissioning, because there's always obviously a risk that it sort of destabilizes the people who know, and relationships, obviously. Any transfer across to the ICB, as it has done in the past, there needs to be a transition where the right people are trained. They need to have the experience, unless the same people migrate across in a similar position of understanding and relationships. I don't think it will be a major issue, but I think there will always be inevitably a short period of time where there's a little bit of instability as the new commissioners come to grips with what the role is about and the task it involves and the nature of the service itself, and build relationships with the people who are the service providers.
Thank you. Thank you, Chair. Thank you. Assembly Member Boff.
I've got a kind of sort of a sweep-up question, really. We've heard from the previous panel about problems actually identified by Assembly Member Ahmed about problems that have been around there forever in the NHS that seem to be getting in the way of progress. So I'd just like to ask each one of you, what change in either the institution or the administration would assist you most? Ms. Gross. Or Dr. Ravendi.
I think it's difficult to identify a single thing, but considering the focus of this panel being on inequalities, over my career I've definitely seen an increased focus on inequalities. 10 years ago we barely spoke about it, but now from a commissioning point of view it is a requirement of us as NHS England. It's a statutory responsibility as the NHS that we need to address inequalities, and particularly as commissioners of screening programs. These are big population programs that should be accessible to everybody who is eligible. Where we see huge inequalities, that mandatory requirement, I think, has come a long way. But what I would like to see is, in addition to it just being a requirement on paper, it does require funding. So just as we have a budget for service, there needs to be ring-fenced funding for inequalities and recurrent funding, not just funding where you can do a project for 6 months or for 1 year. Because the issues that we're trying to address, they are deep-seated, and they require many, many years to address, but also to sustain forward momentum without actually going back. So that's the one thing that I would like, a recurrent investment on addressing inequalities. A second area where we have made progress but need to do better is on data and intelligence. Even with the fantastic inequalities analysis that we do, and that we have provided to the panel, a lot of our analysis is based on correlating data at a population level. So we make an association that this borough, because they have a higher proportion of ethnic minorities, this is correlated to breast screening, to lower breast screening uptake, whatever the case may be. But actually what we need is better data, so we can actually see so we can actually identify the individuals that are likely or less likely to attend. So there is something about improving our data and our analytics so we can better understand the nature of the variations, but also to be better able to evaluate the impact of our interventions, whether it's from a research point of view or some of these operational interventions that we've discussed, like the campaign.
Thank you. Dr. Tay, you've already mentioned that the inherent dangers of changing organisations, and that we need to be sure we retain expertise and relationships. And apart from car parking spaces, what else would you like to see change that would enable you to do your job better?
I think a very important part of what Josephine says is actually about understanding of what resources are required and the funding is there. just want to touch upon, for instance, the Royal Free covers 16 boroughs in North London. To give a bit of an inkling of what it takes. So in the last year, we had about 12 health promotion projects. In total, we did over 150 events. We contacted over 18,000 non-attenders who didn't attend to encourage them to attend. More than half of them eventually did come for the screening, and we found 10 cancers. But this is a person-to-person call. We also had a learning disability project and contacted 570 people. 94% of them we managed to enable them to attend, and we picked up 2 cancers in that group. We had a physical disability project booking event. There was over 1,600 women. We had then the BME projects, organized 44 events for the sort of ethnic minorities. So all that is so we can talk about health promotion and how to reach people who are not attending, but these are people, time, effort that's required to do what in theory is what we're supposed to do. So I think a real understanding and support at all levels, commissioning at the service level and trust level, to allow us to retain and build it. Because sometimes in some trusts and services, health promotion is very much a Cinderella. The funding may be there, but they decided that because they need it for something else, it does not happen or it happens less. So I think there needs to be more robustness and resilience built in so we can do all these things, not just from the Royal Free, but everybody in London.
Thank you. I mean, to an extent, you're preaching to the choir here on this committee. It's something that we've promoted on many different subjects about health promotion. And Ms. Gross, is there anything that you would like to add?
Yeah, I just add to what Will said. I think, and just on the health promotion point, seeing a big shift in uptake takes time. And I think what is a worry of mine is that there's real flux in the NHS at the moment. You know, there's real change. And I think we run the risk of losing the experts. And I think it's really important to, like Will said, in terms of understanding the systems, understanding that actually you need those structures in place to actually make a difference. And I think there's, as I said, it takes a significant amount of time to build that trust with communities and to work with those trusted voices. It doesn't happen overnight. And I think that's the benefit of working as a system in London, because you can share insights, you can share what works, you can share what doesn't work. But I think having ring-fenced funding streams is really important. I think as well, what I would like to see, and I know it's on the horizon, is that for breast screening, there was a point in the first panel around updating addresses with your GP practice, and you know we've got a transient population in London, and it's utilising the app. It's making sure that women can access their appointments, they can access their results, because we're seeing that with other screening programmes, and I think it's really important, especially if you haven't updated your details, you're still getting that information via the app, because we know that lots of people use it. So that would be my 2 points.
Thank you very much indeed. Thank you, Chair.
Thank you. That brings us to the end of our session today. So can I thank you all for coming and taking time to share your expertise with us. That's really helpful in terms of our investigation on breast cancer screening. We're going to move on to other business now, but we're going to take a 5-minute break to reset for our next panel and be back here at 12:05. Thank you again to all of you for your contributions. Thank you. Welcome back to the last and final part. Not the last, but least final part of our Health Committee today, looking at public health messaging on the Transport for London network. Can I welcome Nicole Valentinuzzi, Assistant Director of External Relations at the GLA, and Emma Strain, the Customer Director for TfL. Thank you both for joining us today. Emma, it's particularly lovely to see you back as well. If we could just jump straight into Emma, I'll come to you first. Are you able to outline how advertising works on the TfL estate under the current contract and what powers the Mayor has to make use of that advertising space?
Yeah, of course, and lovely to see you all, and thank you for having me back. So TfL has a network of poster sites across the transport network, across all modes, and there are two different types there. So there's a non-commercial set of space, and there's a commercial advertising estate. The non-commercial assets are the ones that you routinely see carrying TfL's own information about public transport and safety and fares. And if you imagine when you're on a tube station, they're often the ones that are on the platform that when you face the train, they're behind you. So that set of poster sites are across the whole network, and we use those for our public information, but they're not commercial and they're not part of our commercial sales estate. That network we share with the GLA, and they have an allocation of space to use on that network for the campaigns that they wish to run. So additional, of course, to that non-commercial estate is our commercial advertising estate, and that operates under agreements with our media partners. They are JC&Co, who look after bus shelter advertising, and Global, who look after all of what we call the rail estate, but also covers the Tube, the DLR, the Elizabeth Line, trams, Victoria Coach Station, which obviously is not rail, but is part of that collection. So those two organisations manage those contracts for us. And those commercial agreements don't contain provisions that allow the Mayor or City Hall to direct the allocation of advertising. And there isn't a standing power that enables the Mayor to requisition that space for public health campaigns, or indeed any other campaigns for that matter. What the Mayor can do is use the City Hall's own allocation of that non-commercial space, which I know Nicole's team carefully manage. So that's what I think that gives you an overview of the two kinds of advertising and how it operates. I'm sure you've got more questions, but I'll stop there.
I do. So if you could first clarify to me why, in the Mayor's response to this committee, he says there are no provisions in TfL's advertising agreements that allow City Hall to direct the use of advertising space. It appears there is an allocation.
There's an allocation, but that's not the commercial estate. So
so we're not talking about the commercial estate.
Fine. So the non-commercial estate is already shared with the GLA for them to use for campaigns.
Okay. So why was it suggested that this is intended for TfL operational messaging only?
I think perhaps there's some confusion between the commercial advertising estate and the non-commercial advertising estate here. TfL is able to use some of the commercial estate in limited allocations if there is capacity within that commercial advertising network as part of the contracts that we have with Global and JC&Co.
But clearly the committee wouldn't be interested in asking about that. We're asking about the GLA's allocation.
Okay.
So that's why I'm confused whether the suggestion seemed to be from the Mayor that there wasn't a way to influence essentially the messaging that's seen on TfL, but there is.
I mean, I can go back and look at those letters, but what we're referring to when we talk about what the Mayor can't influence is he can't direct TfL to use its commercial advertising space. And we already provide information on the non-commercial space.
So on the non-commercial allocation to the GLA, what is that allocation?
I don't have the information with me today, but there's a network which covers across various different modes, and it's used and allocated between the organisations. So I'd have to come back to you on sort of proportions and numbers.
Nicole, do you have an idea of the numbers?
So it changes quarterly, so it's planned on a quarterly basis. It is primarily the posters on the London Underground. There are sometimes bus shelters or wrapped buses, DLR trains, and then on tfl.gov.uk. But it changes quarter to quarter.
Do you know a rough figure of what that allocation looks like?
I don't have I could supply the quarterly breakdown for the past year to the committee after this, if that
Would
helps.
you be able to provide the committee with the breakdown of that allocation over the past 10 years if you have it?
We won't have 10 years of data, but I suspect we'll have some data.
Yeah.
Can we have the data as far back
as we can.
as you have it.
Yeah.
Okay.
Of course, yeah.
So, just to differentiate, what would you classify as a TfL operational message?
So it might be something to do with our public safety campaign, so things like mind the gap, stand clear of closing doors, all that kind of safety information. It could be information about changes to fares, options about capping. It might be used part of our purpose campaign, which we use to communicate changes and improvements to services, whether there's options for customers in terms of new things that they can do. So those kinds of things are what we would consider as part of our everyday communication to customers.
Okay. So if I take a look at one of the boards that I saw recently at Green Park on the underground station, you had 3 of the, with your back to the wall facing the train, those ones behind you here. There was 3 in a row. There's one which was completely empty, dead space. The next one says, it said 2019, and then underneath, cycleways, feeling the wind in your hair. The next one said, ULEZ is working. Those 2, would they be mayoral GLA ads or TfL operational ads?
I think the cycleways one is definitely a TfL ad.
So that's a TfL operational advert.
Message to
and
make
all
people
it says
aware of
is 2019 cycleways, feel the wind in your hair. It doesn't tell you where you'd rent a bike. It doesn't tell you where that cycleway is. It isn't any help to tourism. It's
I think I'd
just
need to
a
see
political message.
I think I'd need to see the picture to make sure I'm saying that is one of ours, because we do have messaging. So, for example, we have a cycling campaign which highlights improvements when we build and open new cycleways. There'll be a promotion piece to make people aware of those new cycleways opening. So I'd need to check, because you'd understand we run quite a lot of different messages and I don't have them all in my head. So my suggestion is I go away and look at that one, if you've got a picture of it. And
I do, yeah. And I think you maybe hopefully understand where we're coming from as a committee, trying to understand,
of course,
the advertising here and the breakdown. So we're looking to understand what is the TfL operational messaging, what is the mayor's and the GLA's allocation, where is the space that we could use for health promotion. So just looking at those messages, I'm trying to understand what falls into the mayor's messages and what falls into TfL operational messages.
I'm very happy to come back to you with a sort of broad overview of all the campaigns that TfL is running in that space.
Okay.
It's no problem at all.
Because I think those 2, for example, to me, they have a TfL aspect to them, but they are very much mayoral messages, political messages. They aren't operational messages for TfL. So I just want to be clear about where we are, if we can
If I can provide a summary to the committee of the campaigns that are running with some examples of those assets, then hopefully that'll be clear, because it's very difficult if you just we describe things to know that we're talking about, not talking at cross purposes.
Thanks. Assembly Member Boff?
Have you done 18?
No, that's you.
Oh, it is me. Oh, right. Oh, well, that's good. I've got the wrong question, but it doesn't matter. Just to add to that list.
Just to say, don't do the next one, because that isn't
Yeah.
yours.
Yeah, that isn't mine. Yes, okay. Okay, sorry. The reason that I'm confused is I was a little late for the pre-meeting. We have pre-meetings to decide who's going to get questions. And the reason I was late is because I thought, well, let's go and have a look at some adverts on the tube.
I didn't see the time, Andrew.
So I went to the DLR and I saw a piece of on the information board. It says, every fare you pay goes back into the journey you make. That was it. We saw one that was marginal, I suppose. This was at the DLR. Yes, I can see the DLR in the background. It says, be kind, please show respect to each other when travelling on the network. There's an argument you shouldn't have to even say that. There was another within the tube itself. Our entire bus fleet is 100% low or zero emission. Well, that's interesting to know, but it is not an operational advertisement. And that's from about 20 minutes of getting into the tube. There are things that are marginal. I accept that some public information about sexual harassment and all the rest of it, entirely worthwhile. I get that. clearly, TfL do allocate advertisements to non-operational matters. For years, we've had poems on the underground, so we know that we know it's there. We know the facility, the possibility is there. What we're saying is, the committee. I think I'm speaking for the committee. If I'm not, I'm sure they'll say no. But what the committee is saying is that there are plenty more important public health messages that need to go out, and the mayor has an enormous resource there of of presenting information to the public. And in fact, he was moved. So what I'm trying to understand is how they decide what's a good message and what's a bad message. And I was a little confused by what you said earlier about there is a part of the commercial estate that is used for TfL. Well, that's what we want to know about as well, not just the stuff that TfL controls, but that commercial stuff as well. What opportunities there are. And it just doesn't stack up that the mayor doesn't have the power to do it. It doesn't seem to make sense.
Okay, so, I mean, one point...
That's a lot, and forgive me, but there was a lot to look at on the tube.
Fine. The one point I'd like to come back on and the messaging around that be kind message. I mean, the number of incidents of workplace violence, aggression against TfL's operational staff every week is an eye-wateringly large number. Yes. And therefore, actually, those messages about customers being kind to themselves and being kind to our staff are really important. It's all about trying to set that tone.
Except that one. I'm not, perhaps I shouldn't have mentioned it because, as I said, it was marginal. It was a marginal thing. Yeah, but certainly what's not marginal is something telling us that, for example, TfL is a non-profit organisation. Great.
The money that we make from commercial advertising is put back into maintaining and improving the network.
Yeah, but one of these adverts tells us that TfL is a non-profit organisation, and that's the only function.
You're going to have to forgive me. Please, I'm very happy to look at them all.
You will send them.
It's very difficult to do that without looking at what you're looking at.
There's those images as you go up in central London of that happy bearded gentleman tapping in and out on the. No, not you. Not you, Assembly member. You're not that happy. But tapping in and out, and it's repeated time and time again on the video links that I absolutely get. I don't want to take away any commercial opportunities from TfL, none whatsoever. But what we do know is there's potential there for filling those spaces that we do have with more useful messages than every fare you pay goes back into every journey you make, or self-promotion of the mayor, which is legion.
And so I guess it's just worth explaining a little bit more about those commercial arrangements, if that's okay. So, as I've said, they are with JC&Co and Global. They hold the rights to carry the advertising across that commercial estate, and that provides important revenue to us, as I've already said. There is a small amount of the assets in that space that are then provided to TfL if they're available. And the challenge for us is that what I'm not able to do is to tell our advertising partners that they should be carrying other people's campaigns in that space. And that's very much because the vast majority of organisations that want to advertise in our space buy that advertising. Well, all of them buy advertising space. Okay. And I think the point about that is that if I then say to my advertising partner, I want you to carry an advert from X organisation or X charity, of which there are very many who would quite like free advertising from us, then what they will say to me is, well, that space is sellable space, and therefore they would need to... And the way our contracts work is it's a revenue share arrangement. So if they sell space, then the revenue is shared between the two organisations, between the contracted organisation who does all that work to manage it, and the revenue comes back to TfL. So the reality is, what they would say to us is, if we want to start giving away space to other organisations, the vast majority of whom buy space commercially, I would have to compensate them for that happening. They'd also have to agree to that to happen. So while these things aren't necessarily impossible to do, the commercial reality is that it would come back to me to have to compensate them and make a contractual change to our agreements with them to enable other things to be shown. And that compensation means TfL is then paying for those adverts to be shown on the network.
Well, that's precisely what we're asking you to do, to make it possible.
And the challenge for me is that that income is required for TfL.
Once again, I am not in the least interested in taking any income, but I find it impossible to believe that you can't negotiate a contract which already has a clause in there for TfL adverts, promotion of TfL, that can't include public health messages.
And the reason it doesn't is because there are so many other isn't just public health messages, there are so many other organisations and good causes and important things going on, and therefore what we've done is said, actually, this is strictly only for transport messaging.
Well, that's the restrictions that, I'm sorry, I'm making this a dialogue and I don't intend to. That's what we're asking you to change. Yeah, that's it. It's beyond me.
Because it just feels like TfL is a public body and has public purpose at its heart. So obviously there's a tension between public purpose and revenue raising, which is all baked into the current contracts. But just when does that contract come up for renewal?
So they come up for renewal in, let me count the numbers, 2033.
So I suppose the question is TfL thinking about that contract renewal process and working towards baking in more public purpose in the way that advertising space is used to enable London to share important public health messages?
And that's that challenge, isn't it? It's the balance between is that more important than the income coming back to TfL in order for TfL to improve its services? And that's a difficult balance to strike, but that's what we're talking about, is that actually if we bake those things into future contracts, then that's income that doesn't come to TfL. And actually our purposes are about running a transport network, essentially.
Yes, although it is a public body doing that, and therefore public health messaging is important, but I'll hand back to the Chair. Thank you.
Thanks. Nicole, how does GLA work with TfL to place mayoral ads? What's the process of that?
So, as I mentioned, the space is limited and planned on a quarterly basis. Effectively, the campaigns are agreed in advance.
Double check. Is that space that hasn't been sold then? Is that why it changes on a...
No, that's non-commercial space, so it's never for sale.
So why does it change on a quarterly basis?
It changes according to what's already running on the non-commercial space. We get given an allocation on a quarterly basis.
So we flex it by campaign. So if there's different kinds of campaigns running at different times, then we might flex those things between the two organisations.
Right. So
but it's not essentially a large change in volumes quarter by quarter.
So TfL might otherwise be using that space, is that?
So it's shared between us, but you might find that there's, perhaps, for example, TfL is doing something that wants to use some limited space on the DLR, so actually we might use that for one quarter period, but actually the next quarter we might not need to use that, we might hand that, and that might be part of the GLA's allocation. So we're flexible about how we use that total capacity between the organisations.
And does it work
but with
the other
broadly
way?
the same balance.
Does it work vice versa? If the GLA says we want to run this campaign,
the best we can,
as much as possible, we try to work together.
But I mean, Nicole's shaking her head. So.
I would love to be able to use more of the space, but for all the reasons that Emma's already stated, it is limited. Yes.
But that essentially seems like it is a two-way negotiation of...
Over that small space, it is a two-way negotiation, absolutely, because we have to make sure the campaigns that we propose to run are compliant, and we have to work with TfL on that. Yeah.
Okay, sorry, I just wanted to clarify that, but you were going to tell us the process. Sorry.
Yeah. So the campaigns are agreed in advance. They're coordinated through our media agency, and they're subject, as I said, to TfL legal approval. We make the decisions on which campaigns to run, we base that on the mayor's statutory duties to keep Londoners informed of his policies, the mayoral priorities, and so that's why we end up running campaigns that are around youth programming, public safety messaging around major events. So you'll see there's New Year's Eve posters on the Underground residual at this point. They'll be swapping out. And signposting to services like reporting rogue landlords. Again, right now, as it is wintertime, we run our StreetLink referral posters because this is a time where we know people make more referrals. So, that's a campaign we'll run on the space every winter, for example, along with New Year's Eve, for obvious reasons.
Okay. And this isn't to say that you would, but it is entirely possible that you could use that space for health messaging.
Yes, it's possible in as much if the GLA is supporting a program specifically, or if there is a mayoral...
So the mayoral priority, for example, is ending HIV by 2030, or new transmissions. That is a mayoral priority. Thus, a campaign to increase testing would make sense.
It would be entirely possible. It would have to come through the health team to us, and we would look at what campaign we could run to support it.
So when we are told that it's not possible, that's fundamentally not true. The answer is, I don't want to do it.
Well, I don't think it's not wanting to do it. I think there are a long list of priorities that need to be measured.
Alternative priorities is the correct answer, right? Not you, the mayor. I have alternative priorities, not I can't do it.
Well, I mean, I can't speak for the mayor, and I can't speak for the deputy mayor for health and how they fit it.
The beauty is you can speak as the officer that's not going to, that has to tell us what the fact is, and the fact of the matter is it's entirely possible.
Anything is possible if it's a priority.
It is possible to run the health campaigning messages that we have asked.
But it has to be, yes, anything is possible, of course, but it has to be part of the GLA's organizational priorities, the mayoral priorities, and it has to be a response to
I can't say I'd like to sell Pokemon cards. Mr. Mayor, can you put my Pokemon cards on your ad space? That's not possible. But what is possible is to put health campaigning messaging that the mayor has priorities in health inequalities. It is entirely possible to do that.
Yes, it's weighed up against other matters.
Okay, all right, thank you. Assembly Member Harani.
I think that might be the first reference to Pokemon in the City Hall chamber. But no, just want to ask firstly about, so in the past we have had free advertising space for during the COVID-19 period. Would that have been non-commercial or commercial space that's been used, or both? Sorry, microphone.
You turn the mic back on, apologies. The challenge there is it was a completely unprecedented time. So there was messaging on the TfL estate, both the non-commercial estate and the commercial estate at that time. The reason, I mean, it was an unprecedented time, I'm sure, as the Health Committee you would agree. And the challenge there for us was that we needed to get those messages out in those very difficult circumstances. The other challenge was that it didn't sort of cut across our contracts in the way it would in normal operating, and that's because there was very little advertising going on commercially on the network, because of course brands and organisations weren't buying advertising because people weren't travelling, because everybody was at home. So the difference there is that there was lots and lots of available space on the network because sales of advertising were so low. So it was an unprecedented time, and that's the difference really in that practical sense.
Yeah, and I don't really want to go into the whole kind of I don't want to probe too much on the commercial, because I understand obviously the need for TfL to raise revenue, but any space that's not sold, so I imagine that could be up to 10%, is that correct?
It's impossible to sort of quantify, because the way the advertising is sold now, very much there's huge amounts of digital advertising on the network that's sold in almost real time now. So it's very difficult to say at any point in time what the percentage of unsold inventory is across the whole network.
Okay, but do you have access to some of those unsold spaces if they become available?
Yes.
Okay, and so those would also be avenues or potentials, but you wouldn't have. What I'm trying to get an idea of is for those unsold spaces, which you might not know are coming into fruition or not. Do you have then a list of campaigns that are ready made to go onto those unsold spaces?
And that's where we would put some of our TfL campaigns in those spaces. Yes.
Okay, and then moving to the non-commercial. So I suppose I want to sort of maybe go back as to why we come to this position as a committee, because we look at obviously numerous health issues that impact Londoners, and one of the main issues that always comes up if we're looking at health conditions, particularly health conditions, actually HIV is a good example, is when panels of experts tell us that we need to increase testing, for example, and one of the ways we can increase testing is to raise awareness. And this is obviously an issue that impacts Londoners, but also is in the Mayor's health inequality strategy. So it actually does align with work that the Mayor is doing and priorities from an even policy perspective around looking at health inequalities. So our health inequalities, so this is probably more a question for Nicole, so when you look at all the issues, and you've clearly said that it needs to align with mayoral programmes and mayoral activities, whether it's policing, transport, but health inequalities is actually one of those statutory duties. Is that thrown in the mix, or how heavily is that weighted when looking at what you're looking to promote to Londoners?
So, well, the first thing to say is we're always open to hearing from partners, people who are running specific campaigns, have aims that we can support with. We regularly support and promote activities across our other channels. So obviously the TfL network is not the only channel available to the Mayor and to City Hall. So we use those channels to raise awareness quite often, whether it's social, I mean, it's primarily social, it has to be said. But yeah, we're open to hearing from partners.
Yeah, so the example I'm going to throw out is I'm going to pick a station at random, which is close to us, Canning Town. Sure. And if, let's say, in some of the data that health providers are showing us, or the NHS are showing us, it's saying that, rates of take-up of breast cancer screening are particularly low in this neighbourhood. Where is the conversation? Is the conversation open to say, hold on, the GLA and TfL have some non-commercial space at this station. Can we work with health experts to put messages out there that might increase or awareness of screening and uptake? Is there scope and capacity for that?
Yeah, if the NHS came to City Hall and made that request, that conversation would absolutely happen. Yeah.
Okay, so I think we probably just need to do a bit more pushing and probing on that, because from the evidence that we've seen or heard from you today, it seems that for the non-commercial, there are greater possibilities than for the commercial, but obviously the space is not as much as, or space on the estate is not as much. But I think even as a starter, if we can get some of those priorities that we've unravelled as a committee to the table to look at some of those non-commercial spaces, I think that would be a good start. And I think it probably just needs to be looked at all over again, because that's not the message that we've been receiving from multiple outputs over the years while I've been on the health committee. So I think that's helpful in its sense. I am going to turn into I'm going to turn to commercial in terms of the commercial contracts, and also one thing that that TfL has done is obviously the banning of fast food ads on the estate. So I imagine that's a directive that has gone out to JC Decaus and Globals of this world about when they're letting out space. But another issue that we've looked at as a health committee is gambling harms, and the impact of gambling on London's community significantly impacts Londoners disproportionately compared to even other areas of the country. Now, we've recommended as a committee that gambling ads are banned on the TfL estate, and the answer that we keep on getting back is about the lack of guidelines to that TfL could robustly hold up to withstand any challenges. So do you have any updates, or has this been looked into? Has it come to your attention, Emma?
Yeah, I mean, I'm aware of it, but I think it's with the GLA's team.
Yeah, so there is no national definition of harmful gambling, as I understand it. Again, this is from the health team, which I am not an expert in. But the government is reviewing gambling harms, and when that work concludes, the Mayor will consider what further action is available.
Okay, so some local authorities have already moved forward and looked into banning of gambling ads. Are you in discussions with them or looked at what they've done?
That's a question for the health policy team, so I will try to come back to this committee with that information from them.
Okay, yeah, if you could and come back to us, that would be helpful. Thank you.
Thank you. Assemblymember Boff.
I'm pleased Assemblymember Harani raised Canning Town. There are 6 very large advertisement sites there, and in each of those 6 sites there is a picture of a member of staff saying how happy they are working for TfL. There is also one advertisement there that tells us about the history of the Jubilee line. I mean, these are lovely things, but...
So the latter will be a sort of permanent fixture as part of the station infrastructure and isn't a piece of advertising, commercial advertising.
No, I don't think so.
The former,
okay.
Again, I don't
I'll
have an
spend another
encyclopedic...
20 minutes going to having a look.
I don't have an encyclopedic knowledge of everything that we put up on the network. So
understand.
I'm very happy to go and look.
You can understand, can you not, how we see all these adverts and think, what are those priorities? And I'm very pleased we've had confirmation that if the Mayor can prioritise a particular public health message, then it can be advertised. That's the message we've got today, which is very positive.
Thank you. I don't know who might be best placed. I think maybe both of you to answer this, hopefully. How can I tell the difference between a TfL operational advertisement and a mayoral advertisement?
The mayoral ads will just have the Mayor of London brand, likely on the bottom. That's the main difference. The TfL ones will have TfL and Mayor of London
both branding.
Okay, so that if they've got the TfL and the mayoral logo, it's TfL operational, and if it's just the Mayor, it's just the Mayor.
Yeah.
So when we look at some of these mayoral ads, some of the figures that we've seen in there, we've seen the one, actually, Nicole, you mentioned it earlier, there was one for StreetLink.
Yeah.
And as part of that, that had a percentage of people that the Mayor's helped, and it failed to mention that rough sleeping's gone up 63% since the Mayor came to office. Is there any checks that TfL do on these ads to make sure that they are statistically clear and they aren't misleading to the public?
I mean, the process that we go through is to ensure that all advertising is compliant with the Committee on Advertising Practice Codes. We do that for the adverts that run on the non-commercial estate, and our partners do that for the adverts on the commercial estate.
Okay.
So if it's running, you can assume it'll be compliant with those. Our view is that it's compliant with those ads. And if people have concerns about whether they're compliant or not, they can report them to the ASA for consideration.
Thanks. I did actually report one of your ads where it said that it was a zero-emission bus fleet, and then had a tiny little small print at the bottom which said at the tailpipe, and that ad got changed. So
we try to learn.
On the advert that I mentioned earlier, the TfL ad, which says simply it's got a photo of someone riding a bike. It says in bold writing 2019. Underneath it says cycleways are introduced so more people can feel the wind in their hair. Then at the bottom, Mayor of London, Transport for London. Mm-hmm. That's a Transport for London operational ad. It's not out of the mayor's allocation.
No.
That's operation. The word is operational. Nothing is operational about this, and I'm not taking a dig at cycleways or cycling. I'm just saying an operational notice would say, above this station, there are bikes for rent. Above this station, there is a cycleway. Here is your closest bike lane.
I think
just saying, feel the wind in your hair is promoting a political policy.
No, I mean, my view would be is promoting the use of cycleways, and that's what we're trying to do. So when I say operational messaging, I think it's not necessarily that as the technical, everything has to be perfectly operational, but what we are doing is talking about what we're doing to improve the transport network across London for Londoners, and saying that there are more cycleways open for Londoners to use so that more people can cycle, and if they want to, feel the wind in their hair, is about telling people those cycleways are there.
But it's not saying that. It's saying that there's 2019 cycleways are introduced. It's saying a political policy was introduced in 2019, and it's not giving any information about how to use that cycleway, where it is, what it does. So it's not helping people to ride, is it? Because it's not giving them that information. But the point of this being, it's hard to look at adverts like that and then hear some of the stories that we've heard in Health Committee and believe that there's not a way to get that public health messaging onto the network. It also feels to me like we're saying there is a small allocation that the Mayor of London uses, which we unfortunately don't have any figures of today, which I thought we would get. There's that allocation, but then there's also this TfL operational notice, which also seems to convene with the Mayor's messaging anyway. So there seems to be a large amount of untapped space that we could use to promote messages that Londoners want to see. Correct?
I think all of the messaging that comes from TfL is about promoting public transport services and the use of transport in London for Londoners. That's what we do with that space, because that's part of our purpose as an organisation, about promoting public transport.
But you see that there could be a way to use that for some of the public health campaigns, especially with the GLA. If the Mayor's getting to promote some of his policies through the TfL usage, then we can really take forward some of these ideas, can't we, that the Health Committee's put forward?
I think there is always a discussion to be had, but we, as it stands, have the priorities that are set out, and there's not much more I can say beyond that.
Okay. I think this has been really illuminating for us. I should say that we asked, I think, by the last count, 4 or 5 mayoral representatives to come to speak to us today, and they all refused. So I thank you for the officer's perspective, at least on this, which is really helpful to us. I don't think there is... Oh, Assemblymember Harani.
I just want to ask about, so obviously you've got the commercial, non-commercial, that's fine, but have TfL ever explored looking more creatively maybe at public health campaigns? So maybe using the tannoy, today is National whatever day, please remember to get yourself screen checked. There's more creative, any more creative ways of promoting maybe public health messages that are in addition to spaces that are out there.
Yeah, and we use those systems really for information about transport on the transport network and safety and security predominantly. We don't tend to use them for anything else.
Would you consider more boards, so public health information boards at stations or bus depots or bus stations to help promote some of those messages as well, if there's space that can be identified for public health information boards?
I think if we can do it within the arrangements that we have, then potentially yes.
Yeah, Nicole, is that something that would?
We'd have TfL's.
There are different. The things like information we put onto whiteboards in stations. Is that what you're referring to? So if you walk into a tube station, you'll sometimes see something that has sort of very current information on it.
No,
is that what you're referring to?
I'm thinking essentially more advertising boards put into stations where there's space.
There is a programme of work going on at the moment to increase the commercial advertising space, but we don't have any funding allocated to increase the non-commercial advertising space. And in most places it's quite limited because we just don't have the the space there isn't enough wall space effectively.
Okay.
Thank you. Assembly Member Ball.
Just to feedback, the Jubilee Line extension history is paper on a board, so it's not a permanent thing.
I'll go and have a look on my way back.
On your way back, you'll see.
Assembly Member Ahmed.
Thank you. Sorry, Emma, going back to what you just said and Assembly Member Harani's question about the announcement system, you're saying that they are used specifically for transport and safety information.
Yeah.
But is there any reason why they can't be utilised? And I'm not saying that every 5 seconds there needs to be an announcement, because that will just, dilute the effectiveness of the process. But there are certain times where actually they could be used. So what's stopping that happening?
I mean, the way we use them currently is very much focused on what our customers need to know at that time. And customers, being frank, complain to us on a regular basis that there are already too many announcements. So it's so we do try to be careful about how much information we are putting out there for people. Not, the tube can be a noisy place to travel around. So we try to limit the information we're providing to customers, what they actually need to know. But in theory, it could be looked at.
Thank you. Thank you, Chair.
Time's running now. They think it's the end. Assembly Member Russell.
Yes, just on that point about using the announcements, I suspect an equalities impact assessment would determine that it probably isn't a good idea to broaden that beyond use for sort of information people need to make their journeys.
It is difficult.
And for neurodiverse Londoners, any kind of oral kind of messaging.
And it's difficult, and not to
can
say
be
that,
difficult.
Yeah, it is difficult, and it's not so that public health messaging isn't important, but of course, actually, so is a whole bunch of other information. And the challenge comes for us as to, are we literally going to be talking to our customers endlessly through the tannoys? Our staff have to cope with that, have to be able to answer questions from customers about what's happening. So it isn't without challenges.
But in terms of the use of the non-commercial, the not TFL piece, it does seem like we do need to be having that conversation with the Mayor about his priorities for use of that space, because the kind of, again, it's the kind of the public purpose, the public benefit of that advertising space needs to be able to be used to spread messages that are helpful to Londoners. And certainly the gambling advertising report that we did was really clear about the public health issues, the suicide prevention possibilities of more advertising around gambling. But I can see that's a conversation for us to be having with the Mayor rather than for us to be having with you.
Thank you.
The issue with all these questions is not, I now have another one, so I'm sorry. Nicole, could you just tell us a little bit more about this process to getting things agreed? Where is there like a steering committee, or I don't know, does someone email you and say that from the Mayor's team and say this is what we want to put on? Is there a way you categorise the ideas and then decide what you're going with?
So it's not a steering committee. The head of marketing will come up with a plan that is based on some of the public insight into what Londoners want to hear from us, some of the seasonal, so Street Link, for example, or PQTs coming up, we advertise that, or New Year's Eve. So there'll be a forward-facing plan that is completed at officer level, reviewed on a quarterly basis against what allocation City Hall has, and then those ads are submitted for sign-off through legal and then carried.
So is that the head of marketing within the Mayor's team?
No, that's the head of marketing that reports to me, yeah.
So this is City Hall space?
Yes, yeah, it's City Hall space.
It's not mayoral space then? to a degree. It's City Hall space.
It's allocated to City Hall, and it is used. It is the mayoral priority space. But yes, we do also use it for our statutory event advertising and advertising of the community events at Trafalgar Square. So, yeah.
So if it's City Hall space, we should have more of a say in what happens. Well, you're not saying no, Nicole, which I
is
think
that a
means
question
yes.
or a demand? I'm not entirely.
No, it's a genuine question. If it's City Hall space, then surely City Hall should have more of an influence in what goes into it.
If that is your position, then that is your position. I can't answer that question. The City Hall does have operational messaging that is carried there as well around the statutory events. So yes, there is that in the process, in the mix.
Okay, so can we be brought into this process more then? I mean, so I know that obviously the Health Committee's made these recommendations, but I think someone was saying, was it housing? It came up the other day as well, about housing wanting to push a message. And not just me on a whim approaching you and saying, can you do this message? But if something's agreed unanimously by a committee in a report, that is something that we should be able to come, and that should be discussed with the head of marketing. If it's an interesting idea, we should have that influence.
They're always willing to have that conversation and keep that open. As I say, there is we balance it against all the other priorities, but there's no reason why that can't be a conversation. Absolutely.
Brilliant. Yeah, well, let's see how we go. And then, all right, well, thank you. That really... No, we were going to the wrong place. Okay, all right.
Well, I think you still need to ask the mayor,
Bearing in mind the evidence we've just heard in the previous session about the identification of breast cancer as a result of public information programs that have been run by the NHS, I hope that that's going to be one of the first to be considered by this committee as a request. Well, there is a backlog. This is true. We'll have all these organisations fighting each other, but, you know, the public... we need to emphasise how important public health messages are, how very important. And they're always treated... I think we had a quote earlier that it's always the Cinderella part of the post. People don't think they're very important. They're just fillers. No, they're very important. And that's why we've made such a big thing about this. But thank you, Chair.
Yeah, and I wouldn't want to leave the committee with the impression that City Hall and the mayor doesn't already support public health messaging across all the other channels that are available. You know, this small bit of inventory is one part of that.
Okay. All right. Well, thank you so much, Nicole and Emma, for joining us today. And Emma, once again, lovely to see you back. So take care for the rest of the day, and you can leave. We are going to be finished in a second anyway. So can we all note the report and today's discussion? Can we delegate authority to me as chair in consultation with group lead members to agree any output from both this discussion and the previous? Thank you. Moving on to the committee's work programme. Can we note the committee's work programme? And the date of the next meeting will be on the 4th of March 2026 at 10 a.m. in the chamber. There is no urgent business, so I declare the meeting closed.